Good afternoon, sir.
Good afternoon, sir.
Good afternoon. Good afternoon.
So, a very good afternoon to one and all. This is Dr. Shakti Dasan, Assistant Professor from the Department of Pathology, ESIC Medical College, Hyderabad. Welcome you all for this August gathering on the CME on male infertility. Infertility is a disease of the male or female reproductive system affecting millions of people worldwide. Estimates suggest that between 48 million couples and 186 million individuals live with infertility globally. Male partner is solely responsible in about 20% of the cases, and in almost 30 to 40% of the cases, he is a contributory factor for infertility. It's not a disease of new age. Rather, male infertility dates back to centuries before, say in Ramayana and Mahabharata even. Let me share a small incident from Mahabharata. King Pandu was cursed by a sage that he dies immediately if he performs sexual union. Since he could not bear offsprings, he renounced the throne, but Dharma demanded children. His senior wife Kunti then went on bearing children through mantras where Hindu demigods impregnates her womb. Even in Ramayana, King Dasharath was the first ever known man who was documented infertile. Probably our new age techniques have their own deep-rooted history and similarities for assisted reproduction techniques in male infertility. With this brief note, I welcome all the distinguished speakers for this event on male infertility. So I would like to ask our beloved Dean, sir, to have a few words with our gathering. Sir, over to you, sir.
Thank you. Thank you for your kind words. I'm very happy that the Department of Pathology, which has combined with many other departments, infertility cuts across all the departments, right from the reproductive medicine, then pathology, urology, obstetrics and gynecology, and a whole lot of new things. There is andrology and all that. And I'm very happy that the pathology has taken the lead and got all these people. I see the people from all specialties who are on board here, and I'm sure this conference will add up to the things. Now it's a time I think we should think of offline meetings and the CME's workshops also. I know this must have been planned during the COVID time. Eventually, Dr. Shakti Dasan, I think we must go for a workshop on this because we have a robust urology department now. And we must also go for assisted reproductive technology unit also from the Department of Obstetrics and Gynecology. I think we must plan something workshop there where you can get all these doyens from India and then start these units in our own hospital, because this is where all the people have to sit together and sort out. We may have excellent department of say urology, but unless we sit together with everybody, we will not be able to give the excellent treatment for the infertility, especially the male infertility, because it cuts across many departments. So with this, I thank the department for having taken the lead, bringing all the people here, and then look forward that we start this male infertility clinic and then IVF centers and other things in our hospital. Thank you, Dr. Shakti Dasan. Thank you. Over to you.
Thank you, sir. Thank you for your kind and encouraging words. So we will now begin with the prayer song.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा सर्वकार्येषु सर्वदा सर्वकार्येषु सर्वदा
So, yes. So, here with myself and Dr. Tejomai, our senior resident from the Department of Pathology, we both will be hosting the session. So, a few words from Dr. Tejomai.
Good afternoon, one and all, my seniors and colleagues. I'm Dr. Tejomai, senior resident from Pathology Department. So I just want to introduce Dr. Krishnakant sir. It's my immense pleasure to welcome our HOD, Dr. GVRN Krishnakant sir, who has done his MD Pathology from Guntur Medical College and PDCC in Oncopathology from Amrita Institute of Medical Sciences. Sir is currently working as professor and head of the Department Pathology at ESIC Medical College, Hyderabad since 2019. And sir has many publications, 15 publications in various national and international journals to his credit. Sir, we are eager to listen to your talk on epidemiology and pathophysiology of male infertility, sir. Over to you, sir.
Thank you. Greetings to Dean sir and Ratna madam and our assistant professors Dr. Shaktidasan and Tejomai. Thank you for inviting me for this talk. And I would now want to share my screen. Dr. Shaktidasan, if you can
Yes, sir.
stop sharing, I would proceed to share.
Yes. Yes, sir. Sir, you can go ahead, sir.
Krishnakant sir, please switch on your video, sir.
Are my slides moving?
Yes, sir. Please switch your video, sir. We are not
Yeah,
able
yeah.
to see you.
Yes, yes, ma'am. Are you able to see my screen, Dr. Shakti?
Yes, sir. Yeah.
Are the slides moving?
No, sir. No.
Are they moving?
Yes, sir. Yeah. Yes, sir.
Thank you. Sorry for that inconvenience. Yeah. Today I'm going to discuss about male infertility, its epidemiology and pathophysiology. And let us first go to the, before we go into the topic per se, I would want to discuss about the embryology. In human embryos, the default sexual differentiation is always female. However, Y chromosome defines differentiation into the male phenotype and the male reproductive system. The Y chromosome contains the sex determining region SRY gene, which encodes for the development of the testis. And the testis is known to descend from the posterior abdominal wall during development to lie in the scrotum at maturity. The testis develops the Sertoli cells, which help nourish the developing sperm cells. At the same time, they also begin the process of spermatogenesis in the testis. And the testis, it also produces the MIS substance that induces the regression of the female reproductive tract. This is the most important process to happen, so that the way is given for the male reproductive system to develop. Also, the testis develop the Leydig cells that produce testosterone, which is the major driver of the male reproductive system. Not only it stimulates the Wolffian ducts in the male fetus, which later become the testis, epididymis, vas deferens, and seminal vesicles. Now, let us just a recap of the anatomy of the male reproductive system, which consists of the pair of testes, a network of the excretory ducts, which start from the epididymis, progress to the vas deferens, and then the ejaculatory duct, the seminal vesicles, the prostate, the bulbourethral glands, and the penis. This is the outline of the male reproductive system anatomy. Then going to the physiology of the male reproductive system, the onset of puberty is signaled by high pulses of GnRH secreted by the hypothalamus, which in turn signals the release of FSH and LH from the anterior pituitary gland, which later on responsible for various other events. The FSH causes the Sertoli cells of the testis to begin the process of spermatogenesis, and at the same time the LH, which stimulates the Leydig cells of the testis, and testosterone secretion is caused by this, and it causes the development of secondary sexual characters in the male. As spermatogenesis and testosterone production increase, the Sertoli cells produce inhibin, which inhibit as a negative feedback loop, inhibit the release of FSH and LH from the pituitary gland. This is how the fine regulation of the physiological effects of hormones takes place within the male reproductive system. Then this is the pathway of synthesis of various steroid hormones. Dehydroepiandrosterone is the main important primary substance, precursor substance, from which by the action of 3-beta dehydrogenase androstenedione is secreted, and which later on converts to testosterone, which with 5-alpha reductase activity is converted into dihydrotestosterone. And at the same time, by the action of aromatase, it is converted into estradiol. This understanding these events is very crucial to understand even infertility, and the increase of aromatase leads to more conversion of testosterone to estradiol, thus inhibiting the secretion of testosterone to dihydrotestosterone. Now coming to the main topic, that is the infertility. Infertility is defined by the World Health Organization as a disease of the reproductive system, defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. And this can be of primary infertility, where the couple are infertile from the beginning, and secondary infertility after a child or two, they become they fail to conceive further on. That is the secondary infertility. Now coming to the epidemiology of infertility. The epidemiology of infertility is very difficult to state because of several reasons. Infertility affects approximately 50 to 20% of all the couples. Epidemiological studies are numerous, but even considering the all data available today, none is able to define the incidence of male infertility. Male factor infertility can vary widely based on geography and inherent risk factors from 6% to 50%. It should be re-emphasized, however, that the true extent of male infertility is probably underestimated because of the frequent lack of assessment of male in the diagnostic workup of infertile couples. This is the major reason why we have taken up this topic actually. So for various reasons of cultural and other reasons, these male assessment is very infrequently done in our settings. And that's the reason why the male infertility assessment is not correctly done. Then coming to various risk factors, the various risk factors include the age, the lifestyle, the cigarette smoke, substance abuse, sedentary lifestyle, scrotal temperature, exposure factors like toxic and environmental and occupational, family history of infertility, low antioxidant intake, high energy intake, low intake of polyunsaturated fatty acids, high consumption of red and processed meat, low fruits and vegetables consumption, and high saturated fat intake. Now, coming to the distribution of causes of male infertility, traditionally the male infertility is divided into pre-testicular causes, testicular causes, and post-testicular causes. The pre-testicular causes vary from 5 to 10%, the testicular causes from 65 to 75%, and the post-testicular causes vary from 10 to 20%. These various causes are further elucidated in the following slides. The hypothalamic and pituitary disorders, which constitutes the pre-testicular causes of infertility, constitute the idiopathic isolated GnRH deficiency, Kallmann syndrome, single gene mutations, and infiltrative diseases, hyperprolactinemia, and a list of other causes, including drugs, critical illness, systemic illness, infections, and obesity. Then moving to the primary gonadal disorders, which are otherwise also known as testicular causes of male infertility, which includes the Klinefelter syndrome, Sertoli-Sertoli syndrome, and germ cell arrest, Y chromosome deletions, single gene mutations, cryptorchidism, varicoceles, infections like mumps and orchitis, and other miscellaneous causes including drugs, radiation, gonadotoxins, and chronic illness. Then coming to the post-testicular causes, which include the sperm transport disorders, they mainly include the epididymal obstruction or dysfunction, hypospadias, congenital bilateral absence of vas deferens, infections, vasectomy, herniorrhaphy, cartilaginous syndrome, Young syndrome, ejaculated dysfunction, and cystic fibrosis conductance regulator gene mutation. So these all come under the post-testicular causes, which are otherwise also known as sperm transport disorders. So there is another way of looking at these causes when you do the semen analysis, that is by calling them as obstructive agiospermia and non-obstructive agiospermia. Obstructive agiospermia constitutes the post-testicular causes, and non-obstructive agiospermia constitutes the pre-testicular and testicular causes. Now going to the, I will just overview all these because these are going to be covered in detail by the other speakers. The important causes include the Klinefelter syndrome. The Klinefelter syndrome is the most common numerical sex chromosome disorder in males caused by aneuploidy, affecting 1 in 660 newborn males, and it is usually associated with 47XXY karyotype, which may be sometimes a full trisomy or in the mosaic form in 15% of the cases. This syndrome generally causes spermatogenesis arrest at the primary spermatocyte stage, but occasionally later stages of sperm maturation are also observed in certain cases of Klinefelter syndrome. The common clinical signs include the taller, less muscular body, broader hips and longer legs, the larger breasts, the weak bones, low energy levels, smaller penis and testicles, and delay in puberty and less facial and body hair following puberty. These are all the various signs that are associated with which we can recognize the Klinefelter syndrome. Then going to other chromosomal disorders, the chromosomal translocations, there are certain chromosomal translocations that usually affect the spermatogenesis, and also the Y chromosomal microdeletions. These microdeletions frequently occur on the long arm of Y chromosome, YQ11 region, and they lead to agiospermia. At the same time, another important cause of these genetic disorders is the CFTR gene deletions or duplications. That is a cystic fibrosis transmembrane conductance regulator gene, that is the CFTR gene. Genetic mutations in this gene is responsible for congenital bilateral absence of vas deferens, which is abbreviated CBAVD, and cystic fibrosis. Then we move on to the other important cause, that is the male idiopathic IOT, that is oligoasthenoteratospermia. Male idiopathic oligoasthenoteratospermia is defined as a defective spermatogenesis of obscure etiology and is regarded as undetectable unless we use more sophisticated laboratory methods. This IOAT can be classified from a clinical point of view into mild, moderate, and severe depending upon the sperm concentration. The etiology of IOAT include age, non-inflammatory functional alterations in the post-testicular organs, infective agents, genetic factors, mitochondrial alterations, and subtle hormonal alterations and environmental pollutants. Lying to the underlying all these various factors, the pathogenesis can be linked to two important factors, that is the sperm oxidative stress, that is increased reactive oxygen species generation and decreased antioxidant capacity, depending upon the various foods the people take, lead to the imbalance between the oxidation and reduction status within the living systems, which is called as the sperm oxidative stress. The second important pathogenic factor for the IOAT is the interference with apoptosis. Apoptosis is an important phenomenon, which is a physiological mechanism. Apoptosis, as you all know, it is programmed cell death. It normally happens within the cells for reprogramming the tissues within the body. It is a physiological mechanism. It is aimed at achieving optimal cell bar gamete ratio and removing the damaged gametes. Various forms of electromagnetic radiation, environmental toxicants, heavy metals, and chemotherapeutic agents modify this apoptosis. Now, coming to other important factor, that is the obesity, which is growing in as a pandemic proportions nowadays because of reasons most known to everyone. Men's diet is responsible in particular amount. The diet men take, especially the amount and type of different fats they eat, could be associated with their semen quality. How? It has been found that men who eat polyunsaturated fatty acids, fats, have better performed sperms than men who eat less of these, and diet full of saturated fat would cause reduction in sperm count, while diet rich in omega-3 fatty acids would contribute for better sperm morphology. At the same time, there are several other factors. There is role of aromatase, which I discussed while I was describing the hormonal secretions, because when person put on more fat, there is the more synthesis of aromatase, which causes hyperactivity of this aromatase, which converts testosterone into estradiol, thus shifting the person towards the infertility arena. Also, the role of leptin is also important in the obese men, and there is also increased production of resistin in obese men. All these are linked to towards infertility. And there is a large body of scientific evidence which says that obesity is linked to erectile dysfunction. There is several studies are there on this, and also there is another important factor why obesity causes infertility is the rise of testicular temperature. Sedentary lifestyles, prolonged sitting, and fat deposition in the lower abdomen causes increased testicular temperature to the level of body core temperature, which is also incriminated for this infertility in these obese patients. Then we also have unexplained male infertility. So there is a subtle difference between IOAT and unexplained male infertility. In IOAT, the semen analysis is defective, whereas in unexplained male infertility is defined as infertility whereby semen analysis is normal. Genetic defects are regarded as cause of this unexplained male infertility. Genetically compromised spermatozoa used in assisted reproductive technology have been associated with wide range of abnormal embryo development. So, this is this abnormal embryo development is an important factor wherein we need to diagnose this unexplained male infertility, and genetic defects, all these need to be elucidated and they need to be diagnosed, because with this genetic, though the semen count is normal, these genetic, if ART is done with these sperms, it will lead to genetic defects in the embryo. So unexplained male infertility, though the semen count is normal, cannot be left like that and needs to be investigated further. This is an important message of this presentation. The important recommended tests in unexplained male infertility include cytogenetic tests, a gene sequencing test, and a FISH techniques, microarray technology, and NGS technologies, and GeneSat trypsin banding, otherwise called as G banding, which detect the chromosome polymorphisms. So my next speakers will go in detail about this test, but now at this level, I want to emphasize that unexplained male infertility cannot directly go to ART. It has to be investigated so as to avoid embryonic defects. The other important component is the inflammatory infertility, where male infertility is provoked by genital tract inflammation, and about 10 to the majority of the so-called inflammatory infertilities are of prostatic origin with epididymis of marginal interest. Most of the literature agrees that existence of bacteria in the prostate is linked with asthenospermia and decreased male reproductive health, and chronic prostatitis seems to affect sperm count mainly if it is associated with irritable bowel syndrome, wherein there is, because of the dilatation of the periprostatic venous plexuses, there is rise in the testicular temperature and increased production of ROS happens. And these increased ROS also is because of the leukocytes that are involved in the inflammatory process. Other important cause is the mumps orchitis. Mumps orchitis, though it is rare, it is very important cause. The causes of testicular atrophy, why mumps exactly causes infertility, are not totally established. In the course of inflammation, the tunica albuginea forms a barrier against the edema, so that because of this, the edema remains within the testis and causes rise in the intratesticular pressure and leads to pressure-induced testicular atrophy. Mumps orchitis rarely leads to agiospermia, more frequently leading to various degrees of dyspermia.
So, sorry
Now,
to
coming to the
interrupt, sir.
testicular causes,
Sorry to interrupt,
cryptorchidism is
sir.
an important cause, testicular torsion, testicular microlithiasis, testicular trauma, and testicular neoplasms. These will be more in detail dealt with under the heading of testicular biopsy talk. So I am not going into the details. I am just giving you an overview of these testicular causes. Then we also have endocrine infertility. Male infertility is caused by endocrine alterations in at least 18 to 30% of cases. It can be primary hypogonadism, where the testis is at fault, or secondary hypogonadism, where the pretesticular things, that is the GnRH secretion, LH secretion, FSH secretion, all these are at fault. So the primary hypogonadism, otherwise called as hypogonadism hypergonadotrophic. The name is because the FSH and LH are normal or sometimes elevated in these cases. Important causes includes anorchidism, cryptorchidism, mumps orchitis, Klinefelter syndrome, which we have just briefly discussed, and then LH receptor enzyme defects, androgen receptor defects, Sertoli only syndrome, radiation treatment or chemotherapy, then testicular trauma and testicular torsion.
So sorry to interrupt, sir. Running out of time, sir.
Causes are mainly responsible here: failure of the gonadotrophic function, the pituitary, isolated LH deficiency, isolated FSH deficiency, altered LH biological activity, altered FSH biological activity. All these are the important causes of secondary hypogonadism. Then coming to the endocrine infertility, testicular steroidogenesis congenital disorders and androgen resistance syndromes. These are some important causes of endocrine infertility. And hyperprolactinemia, thyroid disease, growth hormone alterations, hyperestrogenism, Cushing's syndrome, and diabetes mellitus are the other important causes which can be grouped into endocrine infertility. Then iatrogenic infertility cannot be complete without covering this. That is the chemotherapeutic drugs induced, radiation induced, and some surgery induced infertility that happens for obvious reasons. And also environmental pollution, which is on rise in these days, endocrine disruptors, heavy metals, and solvents. The role of environmental pollution is also been supported by various studies, that the urban males are more prone for infertility than compared with their counterparts in other semi-urban and rural areas, which clearly indicates the role of environmental pollution also as an important factor of causing male infertility. So those were the brief outline of the causes of male infertility. This is just to give you an overview so that it makes a pavement for the future talks. And to summarize, the causes of male infertility are very many. They may be associated with defects in sperm production or its transport. They can be multifactorial at times and sometimes idiopathic at times. So all the efforts by us, by our doctors, is to explore this idiopathic category, to perform the relevant genetic tests for these patients, to explore the causes of IOAT and unexplained male infertility is what I see for the future of male infertility. Obesity, environmental pollutants, and certain therapeutic agents, they play no lesser role. So proper diagnosis, they must for good results, even before we proceed to IVF. IVF is not the miracle technique that is going to give us the results. This proper evaluation has to happen for these cases. Only then we can expect good results even with IVF. So that concludes my talk. Thank you all for your attention. I now welcome any questions on this session.
Any more questions from the audience side? Okay, if there are no more questions.
Thank you, sir, for the lucid presentation.
Yeah, if you can also put up the questions in the chat box, which we will take up during the course of this CME. If anyone wants to ask questions later also, they can at any time add on the chat box, which will be taken up at an appropriate context. Thank you.
Thank you, sir, for your presentation. It was elaborative yet crisp. Thank you. Thank you so much. Now, I'm honored to introduce our next speaker, Dr. Ravindra Reddy Chira, one of the eminent urologists. Sir has done MBBS from Osmania Medical College, Hyderabad, and MS General Surgery from Kaktiya Medical College, Warangal. Sir has done MCH Urology from NIMS, Hyderabad, and currently working in ESIC Medical College and Super Specialty Hospital, Sanat Nagar, since 2015 September. Sir presented many papers at state, South India Journal, and national conferences. He was awarded GM Phadke Traveling Fellowship of Urological Society of India, and was also awarded with CL Ashok Kumar moderated Poster Prize of South Zone USI Conference. He has published many papers in Indian Journal of Anesthesia. Sir is going to deliver his talk on role of history and physical examination and diagnosis of male infertility. Over to you, sir.
Can I start?
Yes. Yes. Yes.
Sir.
Yes.
Can I start?
Yes.
Good afternoon, everyone. I am Dr. Ravindra Reddy, working as consultant urologist at ESIC Medical College Hospital, Sanat Nagar, Hyderabad. Today, I will be discussing briefly about the role of history and physical examination in diagnosis of male infertility. With the success of assisted reproductive techniques latest, the evaluation of male is often ignored. However, the physician treating should note that many causes of male infertility like varicocele, ductal obstruction, infections are easily and effectively treated. And we have to see that without a full evaluation, significant conditions such as testicular cancer, pituitary tumors, and neurological diseases may be overlooked. With new inroads into the genetic causes of male infertility, the proper counseling and evaluation of the male should be done before going for ART techniques. So the goals of evaluation of male infertility are to identify reversible conditions of male infertility and to also identify irreversible causes that may be managed by IUI or IVF using male partner sperm. Other than these reversible and irreversible conditions, it is also done by donor insemination or adoption. and also to identify significant underlying medical pathologies, and also to identify genetic and chromosomal abnormalities that may affect either the parent or his offspring. The components of history in the evaluation of infertile male includes the physical past history as well as the sexual history. In the sexual history, we have determined the duration of sexual relations, marital life, and the methods of birth control which are being used. And we have to also determine whether the male has proper erections and about his any other conditions like premature ejaculation and other ejaculated disturbances. We should also note about the use of lubricants during sexual intercourse, which may be spermicidal. So, and also we have to determine the frequency and the timing of coitus. Many couples don't know that fertility mostly happens during the mid of the menstrual cycles, during their ovulation period. So the coitus should be happening every 2 days at the time of ovulation, so that proper consummation can be done. We have to also ask for the developmental history, like history of any cryptorchidism, because unilateral cryptorchidism may affect fertility, and bilateral cryptorchidism may drastically affect the spermat potential. We also should be seeing the age at puberty. Is there any delayed puberty or absent puberty may lead to some endocrinopathies or androgen abnormalities. And we also should be asking about gynecomastia, because it is a reason for estrogen excess or hyperprolactinemia. Also, we have to determine any congenital abnormalities of urinary tract or central nervous system, like Kalman syndrome. So we should also be asking about the surgical history, surgeries previously done, like previous pelvic or retroperitoneal surgeries may affect his erectile or ejaculatory potentials because of injury to the nerves. And previous orchidopexy done after puberty may drastically result in sperm defects. This one. Herniorrhaphy, previous herniorrhapy may injure the vas deferens. Previous vasectomy may injure previous vasectomy done, and scrotal trauma or testicular torsion may result in testicular atrophy or development of anti-sperm antibodies. We should also be asking about a previous urinary tract infection or sexually transmitted diseases. In many conditions like prostatitis and pyospermia, even though they are not directly relating to infertility, they may be some predisposing conditions. Mumps orchitis developed after puberty may drastically reduce the fertility potential of males. Any systemic diseases like diabetes, multiple sclerosis may affect his erectile and ejaculatory potentials. And end-stage renal diseases may affect the fertility. Previous radiotherapy and chemotherapy may impair the semen potential for at least 4 to 5 years to return to normal. And previous recent febrile illness we should be asking, because it will temporarily impair the spermatogenic potential for at least 3 months. So when we find that he has a recent febrile illness, we have to ask for a repeat semen analysis after 3 months. And the testicular tumors may also lead to low sperm count and infertility. Previous epididymitis and previous tuberculosis and other chronic diseases we have to be asking the history. Family history, we should be concentrating on cystic fibrosis, as it leads to congenital bilateral absence of the vas deferens, CBAVD. And we have to ask about congenital midline. We have to see for any congenital midline defects, syndrome conditions like Kalman syndrome. And we have to ask any history of cryptorchidism and also hypogonadism. And the drugs may result in low spermatogenic potential, like use of nitrofurantoin, use of spironolactone and other antihypertensives, abuse of cocaine, marijuana may all lead to spermatogenic defects. Occupations like working in agricultural fields with exposure to pesticides may cause defects in sperm this one. And using of sauna and hot baths may impair the spermatogenic potential. And we should also determine whether we have to take history of the past reproductive history to differentiate any congenital issues, prior infertility evaluation and treatments they have taken. And before going for the physical examination, we should also be taking a view of the female reproductive history. General examination, we have to both do a physical examination in relation to the fertility as well as a genital examination. We have to note the appearance and the patterns of virilization of the male. Secondary sexual characters, absent secondary sexual characters imply inadequate androgenization. And acquired androgen defects may lead to frontal baldness absent and loss of wrinkles on the face. And gynecomastia, presence of gynecomastia may denote estrogen androgen defects, hyperprolactinemia, or testicular cancer. In syndromes like Klinefelter syndrome, we will find an arm span 5 centimeter long than the patient's height. This obesity is one of the reasons for conversion of testosterone to estradiol and impaired sperm motility and degraded sperm DNA integrity. Coming to the genital examination, we have to see for the penis to see if there is any hypospadias, severe phimosis, or severe chordae, which may lead to deposition of sperm into the vagina difficult. We have to see for the testis to see for the consistency and also the dimensions. Consistency, if it is not smooth and if it is very hard, may denote any intratesticular mass. And dimensions we have to measure to see for whether the testis size is normal or not, as testis size correlates with the seminiferous tubules, and any defects in the size of testis may denote less spermatogenic potential. And epididymis, we have to see epididymis, we have to palpate, examine and palpate to see for the head, body and tail, whether they are this one proper. An increase in the size of epididymis with cystic enlargement may denote epididymal obstruction. Epididymal cysts and spermatoceles don't normally cause defects in the epididymal flow of sperms through the epididymis. We have to also palpate for the vas to see for the conditions whether the vas is present or not. And we have to examine the spermatic cord and delineate whether he has any varicocele. Grade 1 varicocele is only identifiable with a Valsalva maneuver. Grade 2, if the patient is in a standing position, we have to palpate. And grade 3 varicocele, we can directly see with vision. And these are the scrotal, whether we have to see it is normal or hypoplastic, which can happen in a cryptorchid child. For the testis size determination, we can use these calipers or archidometer, or directly we can go for a ultrasound. Testis dimensions will be of about 4 into 3 centimeters and volume of about 20 cc normally.
So sorry to interrupt, we are running out of time, sir.
And finally, we have to do a perrectal examination to see for the prostate, if it is aplastic or hypoplastic. Also, we have to, if tender is there, it can denote prostatitis. And we have to see for the seminal vesicles whether palpable or not. If it is palpable, it is an abnormal finding suggesting engorgement and ejaculatory duct obstruction. Thank you.
Thank you, sir. It was a detailed presentation on the role of history and physical examination in the diagnosis of male infertility. So any questions? Welcome. Any questions from the participant side? Are welcome. So thank you once again, sir. So our next guest speaker of honor is Dr. Meenakshi Sundaram, sir, who has done his undergraduation from Madras Medical College, MD Pathology from Tirunelveli Medical College, and he has worked at Meenakshi Medical College and Savita Medical College. He has joined ESIC Chennai in 2013, and currently he is working as professor and head of the Department of Pathology at ESIC MC Chennai. So, sir, we are eagerly waiting for your talk on semen analysis, the recent guidelines. It's all up to you, sir.
Okay. So, thank you, Shakti, for that introduction. At the outset, I thank the organizers for giving me this opportunity. Is my screen visible? Shakti?
Yes, sir, your screen is visible, sir.
Okay, okay. So my topic is on semen analysis, the recent guidelines. So the objectives of my talk is in the latest WHO manual of semen examination, what is kept, that is what is retained from the 5th edition, what is new, what is discarded, and a small word about the matter of limits and matter of standardization. So the 5th edition, it has got different parts. The first one is standard procedures that include sample collection, initial macroscopic examination, including sperm motility, sperm vitality, sperm numbers, can have a routine counting procedure, and semen sperm morphology, including staining procedures. The optional procedures include indices of multiple sperm defects, pan-leukocyte immunocytochemical staining, interaction between spermatozoa and cervical mucus, biochemical assays for accessory sex organ function, that is determination of amount of zinc, fructose, and neutral glucosidase, and CASA, that is computer-aided sperm analysis to assess the sperm motility, sperm concentration, and morphometric assessment. The research procedures in the 5th edition of WHO manual is a measurement of reactive oxygen species that is generated by the sperm suspensions, human sperm oocyte interaction tests, human zona pellucida binding tests, assessment of acrosome reaction, zona-free hamster oocyte penetration test, assessment of sperm chromatin. So in general, you all know sperm analysis is the test of choice for assessing the male partner in an infertile couple, and studies linking the quality of ejaculate and fertility around 1930s. In 1980, the WHO recruited a physician scientist to publish a manual describing in detail what is the normal semen parameters of a fertile man should be and how to analyze the semen in the laboratory. Since then, they have updated the manual many times. So semen analysis test evaluates multiple characteristics, but 4 things are generally considered most important. The amount of fluid that comes out with ejaculation, that is the ejaculate volume, the number of sperms, that is the density, the percentage of those sperms that are swimming or the motility, and morphology, that is the sperm that have normal shapes. What is semen analysis?
Sorry to interrupt you, sir. Can you please put on your video?
Okay, ma'am. Hello.
Thank you, sir.
Okay, ma'am. Semen consists of 2 components. Spermatozoa, that is made by the seminiferous tubules of the testis, and seminal fluid, that is produced by the accessory glands that nourishes the sperm. Coming to sample collection, sample has to be collected after 2 days and before 7 days of sexual abstinence, and you have to instruct to the individual that the semen sample needs to be complete, that the man should not report any loss of any fraction of the sample. Coming to the analysis, the physical characteristics of the semen sample, such as the volume, pH, color, liquefaction, and viscosity is measured, followed by microscopy to determine the motility, vitality, concentration, and morphology. Finally, the values are compared with the reference values determined by the WHO manual. Macroscopic examination should begin after liquefaction, preferably at 30 minutes, but no longer than 1 hour after ejaculation. Measuring the semen volume, you should give a pre-weighed cleaned disposable container, and you have to weigh the sample in the vessel which is collected and then subtract the previous value. Measuring the volume by aspirating the sample from the specimen container into a pipette or syringe and decanting into a measuring cylinder is not recommended, because there may be a less volume, loss of volume between 0.3 to 0.9 ml. Low semen volume you can have whenever there is any obstruction of the ejaculatory duct, absence of vas difference, seminal vesicles when they are not developed properly, because these are accessory organs which are going to secrete the seminal fluid. High semen volume can also be encountered whenever there is any active inflammation of the accessory glands leading on to an increased secretion or exudation. Motility. Sperm motility again should be assessed as soon as possible after liquefaction, that is between 30 minutes and 1 hour. If you are going to delay, there may be dehydration, there may be changes in pH or temperature which can affect the motility. So usually it is kept in a clean glass slide. A drop of semen, that is around 10 microliters, can be kept on the slide, which is covered with the cover slip, and you can determine the motility. So the categories of sperm motility, the percentage we are going to give is progressive, that is active movement regardless of speed, which can be in a linear fashion or in a large circle. Non-progressive, that is motility without progression. And immotile, that is there is no movement. You should know the difference between of spermatozoa and the concentration. Sperm concentration is number of spermatozoa per unit volume of the semen, but the total sperm number is total number of spermatozoa in the entire ejaculate, which is calculated by multiplying the sperm concentration by the semen volume. So for counting, you can use manually, that is a new bar hemocytometer. The choice of the counting area, you can determine either the WBC squares or in the RBC squares, and accordingly you can have the factors for multiplication. If you are going to look into the WBC squares, the sperm concentration is calculated by the number of sperms that is counted into 50. So coming to next thing, semen morphology. So after counting, you have to prepare a smear in a clean glass slide, air dried, fixed, and then staining. Staining can be done by any choice. Papanicolaou, Shore stain, or Diffie stain is recommended. So the morphology, head, it appears pale blue and dark blue in the pre-acrosomal and post-acrosomal region. Mid-piece is usually red and the tail is stained blue or reddish depending upon the stain you are using. So abnormal spermatozoas, you can have head defects, that is large or small, tapered, pyriform, round, amorphous, or vacuolated. Neck and mid-piece defects, you can have asymmetrical insertion of the mid-piece into head, thick or bent or abnormally thin. The principal piece or the tail defects include short tail, multiple tails, broken tails, smooth hairpin bends, sharply angulated bends, and tail can be of irregular width or coiled. So all percentage you have to make a note of it. The WHO in the first edition, the morphology range was around 80.5%. That is, to call a normal individual as a normal, he should have the percentage of normal sum above 80%. Now it has reduced in the fifth edition, it has reduced to 4%. So this is the equipment we are using in our center, that is ESIC Chennai, SQAV Gold equipment, which is an automated semen analyzer, which has got various compartments, especially the visualization compartment, where we are going to feed the semen. So this is the measurement capillary. So you have to take the semen sample here, and then it is inserted into the equipment. Millions of sperms are analyzed. A specific wavelength of the light that is absorbed by the sperms in the concentration chamber is converted into an optical density, and this OD reading is translated into the semen concentration by a microprocessor. In addition, you keep a drop of semen in the slide and it is again inserted. Thousands of sperms are analyzed as they move through the light beam, and depending upon the movement of the motile sperm, there is changes in the light disturbances, which are converted into electronic signals, and they are translated into motility parameters. So these are all the various parameters that equipment gives. So you can get the sperm concentration, motility, progressive motility, non-progressive motility, immotility, morphology, motile sperm concentration, progressively motile sperm concentration, functional sperm concentration, and these things. So this is the reference value. So the reference value, there is only a lower reference limit. It is considered if the volume of the semen is less than 1.5, it is abnormal. So it should be not less than 1.5. Sperm concentration. It's should be more than 39. Total sperm number should be more than 15 million. Total motility, that is progressive and non-progressive in combination, should not be less than 40. Progressive motility alone should not be less than 32. A live spermatozoa should be above 58%. Sperm morphology, non-form previously, should be more than 4%. It should be more to 7.2, and seminal fructose should be more than 13 micromole. So the terminologies of semen analysis, you all know, but just a recap: oligospermia, that is the sperm concentration is less; asthenozoospermia, when the motility is less; teratozoospermia, if you have only less than 4% of spermatozoa; azoospermia, no spermatozoa in the semen; polyzoospermia, very high concentration of semen, more than 200 million; hypospermia, when the semen volume is less; hyperspermia, when the semen volume is more; aspermia, that is no semen volume; pyospermia, if you see more leukocytes; hematospermia, if you see blood; and necrozoospermia, if you are seeing only dead sperm. So what is kept in the 6th edition of WHO manual is a basic semen examination, which is recommending only one standard procedure to follow. It has also kept from the 5th edition, what are all the things that are retained? It include extended analysis, that is after the basic semen examination, the sperm DNA damage, that is fragmentation, markers for genital tract inflammation, sequence of ejaculation, semen biochemistry, anti-sperm antibodies, indices of multiple sperm defects, sperm aneuploidy assessment. The research tests which are kept in the 6th edition include measurement of this reactive oxygen species, that is oxidative stress, acrosome reaction, sperm chromatin structure, and stability. The 6th edition has removed the sperm cervical penetration test and hamster egg penetration tests. So matter of limits. For the interpretation of results, there should be a limit between normal. So what is normal and what is pathology or essential? But the problem is that there are no distinct limits, because distribution of data from the referencement do not represent limits between fertile and subfertile. Why? Because the reference population is mixed population, and semen analysis has different goals. That is, semen analysis is done for assessment of male reproductive organ function, follow up on andrological treatment of men, assessment of male contraceptive treatment, choice of assisted reproductive therapy, treatment modality, epidemiological studies. So decision limits are more useful than reference limits. Matter of standardization, global standardization is necessary. So they have commented, they have it's necessary for development of andrology and reproductive medicine. So these are all my references. So I thank my colleagues, my subordinates, for helping me to prepare this talk. Thank you.
Thank you, sir, for your lucid presentation and valuable insights. Thank you, sir.
Thank you, ma'am.
That's a wonderful talk. Any questions from the participants?
So if you don't mind, I do have a question. So how often we have seen hematospermia, sir? Because hardly I have seen one or two cases.
Yeah. But it is mentioned in the manual.
Sir.
We have not seen. We have seen cases with pyospermia.
Sir.
But hematospermia is we have not seen. We have not encountered Shakti.
Sure, sir. Yeah. Thank you, sir.
Thank you. Thank you.
Thank you, sir. It was a very elaborative, as well as it was a lucid presentation. Thank you so much for your participation, sir. Yeah.
Thank you, sir.
Yeah. So I'd like to, Dr. Tejamai.
Yes, sir. Thank you. It's great pleasure to introduce our next speaker, Dr. Leela Rani ma'am, who has done graduation and post-graduation from Gandhi Medical College and currently working as Senior Specialist, Associate Professor and HOD Molecular Pathology at ESIC Sanat Nagar. Ma'am has 10 publications to her credit in national and international journals. Her fields of interest are neuropathology, pediatric pathology, and molecular pathology. We welcome you, ma'am. Over to you.
Thank you, Tejumai, for a nice introduction. Good afternoon, everyone. I'm Dr. Leela, and today my topic is testicular biopsy, its role and evolution in male infertility. So I just want to give a brief introduction. Yeah. Coming to this, the testicular biopsy is an invasive diagnostic tool which is used in the evaluation of male infertility. First, this biopsy was introduced in 1940s by Charney and Hotchkiss in Cornell Medical Center in New York. After that, initially the biopsy was done only to evaluate any case of azoospermia or unexplained infertility in males. So I just, before going into details of all the testicular biopsies, I just want to give a brief introduction on what do we see on pathology in a testicular biopsy. When that comes to you, what is the pathology we want to see? Before that, we want to know what is the normal pathology in a testis. So as all of you know, this is the section of a testis showing one. Here you can see the entire seminiferous tubule with the basement membrane. What is the tubule lined by? It is lined by Sertoli cells. These are the Sertoli cells, which are larger, more pale, with a small nucleolus. And then we have the varying degrees of spermatogenesis undergoing in the seminiferous tubule. So these are the primary spermatogonia. These spermatogonia are smaller than the Sertoli cells. These Sertoli cells are pale. These are more darker with very dense chromatin and scant cytoplasm than the Sertoli cells. These spermatogonia again divided into spermatocytes. They can be primary spermatocytes and these are the secondary spermatocytes. These have less dense chromatin than the spermatogonia. So the order of spermatogenesis continues from the base towards the lumen. So in the lumen, you find these mature spermatids, which are more oval shaped or round shaped, and these mature into spermatozoa. So this is the basic process of spermatogenesis in a seminiferous tubule. This also shows another picture. We see the primary spermatocytes, Sertoli cells. See the spermatids, nice oval, typical to the sperm head. Then you see the mature spermatozoa. So this entire process of development from the spermatogonia to the mature spermatids and then to spermatozoa takes 70 days. So this is the process: spermatogonia, primary spermatocytes, mitosis. Until this stage, these are all diploid cells. Once there is meiotic division at the stage of secondary spermatocytes and then after secondary spermatocytes to spermatids, these are all haploid cells. Okay. So what are the, coming to the indications? What are the indications for a testicular biopsy to be done? To evaluate infertility. When do we evaluate? The most common cause nowadays people go for testicular biopsies to distinguish obstructive azoospermia from non-obstructive causes. That is a major indication for testicular biopsy. Apart from that, we also use when there is hypogonadism, primary hypogonadism. When do we know we have primary hypogonadism? Usually when the patient comes for infertility, we do semen analysis, ultrasound, exam, history, everything, and also do all the reproductive hormones. So when there is increased FSH level to more than 3 times the normal, you suspect primary hypogonadism, then we have to do a biopsy. And then to also nowadays we use for ART. This I'll discuss in detail later. And we also use for management of IVF. Other indications for testicular biopsy are less common causes like vasculitis, to check for any viable tissue after torsion. And bilateral biopsies are recommended after chemotherapy in ALL patients. And in some patients, in minority of patients, there is an increased risk for carcinoma in situ. So all patients who are at risk for any intratubular germinal neoplasia, we have to do a testicular biopsy to know the progression. So in cryptorchid testis, not all patients with cryptorchidism may harbor any intratubular germ cell neoplasia or carcinoma in situ. So only 2 to 8% of the cryptorchid patients may develop carcinoma in situ. That carcinoma in situ may develop into a testicular malignancy. So their testicular biopsy is warranted. Then again, if there is already a germ cell tumor in one of the testes, you have to check for the contralateral testis for any evidence of carcinoma in situ, because in some percentage of cases may harbor carcinoma in situ in the other testis also. Then whenever there are some abnormality findings on ultrasound, there is evidence of microlithiasis on ultrasound, or there is inhomogeneous architecture of the testis on an ultrasonography, also warrants the need for testicular biopsy. So what are the usual methods they do? They can do an open incisional biopsy, a wedge biopsy, or a percutaneous biopsy using core needle or fine needle. The open incision biopsy is still the ideal and optimal method for doing a testicular biopsy. So in case of vasculitis, wedge biopsy is satisfactory. Percutaneous biopsy you can use with a spring-loaded biopsy gun is also useful. So what are the complications on doing a testicular biopsy? There can be bleeding or infection, or there is an increased risk of hypogonadism in cases of small testes. Fixatives. This fixative is important in a testicular biopsy. The testicular biopsy itself is very delicate tissue. So normally we use for all biopsies formalin as a fixative. But if we use formalin for a testicular biopsy, the nuclei, there is shrinkage of the nuclei, there is the tubules also shrink. So the morphological details are not very clear. So the ideal solution we use is Bowen solution, or Hollander solution also preferred for superior nuclear details. But ideally in our super specialty setup, we use a Bowen's fluid. For electron microscopy, 4% glutaraldehyde solution is used, and for immunofluorescence, cryo in liquid nitrogen is used. What are the special stains that we can do on a testicular biopsy? Mason trichrome for collagen, PA stain for cytoplasmic glycogen, and evaluation of any vasculitis for by doing elastic tissue stains. But here we do one more important stain is plaque, that is placental alkaline phosphatase, that is specifically stains the carcinoma in situ cells. So whenever we are suspecting we get a patient a biopsy from a cryptorchid testis, we can do a plaque which will stain specifically the carcinoma in situ cells. The normal cells will not take up the stain. Nowadays, we also use OCT 3x4 on immunohistochemistry to stain the same carcinoma in situ cells. So how do we interpret this biopsy? So it can do a qualitative analysis or semi-quantitative analysis or a quantitative analysis. So coming to quantitative analysis, first we should know what is an adequate biopsy. When do you call the test? Any biopsy in pathology, as you all know, we call it adequate or inadequate biopsy. Adequate biopsy should have at least 25 to 30 tubules. That is the minimum number. Ideally, if there are 100 seminiferous tubules, it is very easy to analyze the spermatogenesis or any abnormalities in the testes. Whenever they are taking the biopsy also, not a single core, they have to take at least 3 cores from different areas, because the same testis can have different areas with different pathologies. There can be mixed pathology in the same testis. So ideally we have to take at least 3 core biopsies from 3 different areas of 3 into 3 into 3 mm. And ideally, each core should have at least 25 to 30 seminiferous tubules. So this is the ideal adequate biopsy. And then we have to evaluate, when we get the biopsy, we have to evaluate the size, number, and the thickness of the tubules. What is the ratio of germ cells to the Sertoli cells? Any evidence of fibrosis is there? And what are you seeing Leydig cells? Are there any hyperplasia of the Leydig cells or not? And how many late spermatids are present in the lumen of the seminiferous tubules? So this will indicate partially, we can correlate the number of late spermatids with the sperm count we are seeing in semen analysis. So what are the patterns of the image? What all reports do we see in a testicular biopsy? They all fit into these 7 categories. Any biopsy, till date, we have done 160 biopsies in the super specialty hospital. And most commonly, our pathologies have been limited to only 3 of these patterns of damage. Usually, we saw only Sertoli cell only syndrome or maturation arrest or hypospermatogenesis. Some cases were of normal histology, of course, and some were of testicular atrophy. So these are the only pathologies we see in a testicular biopsy. Either it is a normal histology, or it can be features of an immature testis, or there can be sloughing of immature cells, there can be hypospermatogenesis, maturation arrest, Sertoli cell only syndrome, or there is hyalinization of the tubules. We'll discuss these in detail. So infertility associated with normal histology, where do you see such cases? So germ cells are present in all the tubules. First, any tubule that is coming to you, you have to assess, are there Sertoli cells? Then you have to see whether spermatogenesis is there or not, and what is the degree of spermatogenesis? Are all stages of spermatogenesis seen or not? Is there any kind of arrest in the spermatogenesis? Then you have to look at the basement membranes, are they normal or thickened? Then you have to assess the fibrosis, Leydig cells, etc. So in a normal histology, everything is normal. Germ cells are present in all the tubules. There is active spermatogenesis with presence of late spermatids in the everything. So the most common cause of this is ductal obstruction. So obstructive azoospermia will give rise to normal histology on testicular biopsy. This obstruction can be congenital or acquired. Some rare causes where you see normal histology with azoospermia is impaired sperm motility, like immotile cilia syndrome. And I want to show some pictures of normal histology. I've already shown previously. You can see the lumen filled with some late spermatids and active spermatogenesis in this tubule. Here also another tubule showing the tubule is almost filled and showing late spermatids in the lumen. See, these are the oval ones are all on. This is a picture of a normal histology. So what are the other causes for infertility with azoospermia with normal histology? There can be varicocele, maybe inadequate sampling, obstructive azoospermia or atresia of the tail of epididymis, or there can be infectious causes. Infectious obstructive azoospermia in cases of patients more than 35 years, E. coli is a common cause. And in less than 35 years, gonorrheal and chlamydial infections are common in patients. Vasectomy, the patient has already had vasectomy and we did not get that history, we'll see azoospermia and normal histology of the testis. Then ischemia will have no adverse effect on the germinal epithelium or the Leydig cells. Then coming to the second histology, we see associated with immature testis in the adult. Why there is immature testis? So this testis will be identical to the prepubertal testis, where the tubules are small, lumenless, lined by immature Sertoli cells and germ cells. And we do not see spermatogenesis, but we can find some spermatogonia or spermatocytes in the tubules, but there will be no spermatids or spermatozoa at all. Sometimes mature Leydig cells are also not present. Immature precursors of Leydig cells may be seen in this histology. What are the causes? There can be reduced gonadotrophin secretion or absent gonadotrophin secretion. Any tumor or cyst or calcification affecting the pituitary villi will reduce the pituitary hormones and hence result in hypogonadism. So there is no development of the testis. There is no development of the testis and the testis will be in the prepubertal stage only. So all the tumors and cysts in the sella or suprasellar area causing hypopituitarism or a craniopharyngioma, or if patient is less than 50 years, or there is anterior pituitary failure, diabetes insipidus, I mean everything affecting the pituitary. Or there can be a congenital deficiency of LH or FSH in the adults, or some syndromes like Kalman syndrome, Lawrence-Moon-Bigel syndrome, and Prader-Willi syndrome will result in an immature testis on testicular biopsy. Also, there can be androgen excess. Androgen excess can be due to either androgen-producing tumor or androgenital syndrome, or exogenous androgen administration. Again, all these also will result in failure of development of the testis and it will look like the immature testis in the adult. So coming to the next pattern of damage, we see sloughing of the immature cells. So when does this sloughing occur? Sloughing means there is spermatogenesis going on in the tubules, but there is shedding of these spermatocytes into the tubular lumina. They are unable to maintain the normal maturation up to spermatids, and they're not viable. They're not able to be, they're not able to stay viable, and they get shed into the lumen. So there will be only sloughing of these cells found in the lumina. There will be mild fibrosis, but normal level of Leydig cells. We diagnose the sloughing of immature cells only when there is more than 50% sloughing of the spermatocytes in the lumen. So what are the causes for these sloughing of cells? Varicocele are commonly associated with this. Mumps orchitis or idiopathic causes. And then coming to the next pathogenesis, that is testicular biopsy showing hypospermatogenesis. As the name indicates, hypo means less. There is spermatogenesis in most of the tubules, but it is in the lesser degree than the normal. So there is spermatogenesis, but less in amount. So there is diameter of the tubules is slightly decreased. There will be Sertoli cells, but the number of germ cells is reduced. But here the Leydig cells are normal. Coming to, I can show you some picture. Here you see that the lumen area looks more in this picture. You have some amount of spermatogenesis, but it is reduced. So this is a picture for hypospermatogenesis. So what are the causes? Usually it is malnutrition or exposure to toxic chemicals, chemotherapy, and genetic cases like advancing age, Down syndrome, or endocrine causes like hypothyroidism, hyperthyroidism, glucocorticoid excess, hyperprolactinemia, ductal obstruction. All these will lead to hypospermatogenesis. So coming to the next pathology, that is testicular biopsy showing maturation arrest. This is also common. Here the spermatogenesis is present in the tubules, but it stops abruptly. Usually the maturation arrest is at the level of primary spermatocytes, very rarely at the level of secondary spermatocytes. So these arrested cells are increased, and sometimes they slough into the lumina. The Sertoli cells, Leydig cells, and tunica, they're all normal. There is no fibrosis. But in cases of complete arrest, there will be total azoospermia. In case of incomplete maturation arrest, oligospermia. Sometimes cases, what do we see? We see tubules with maturation arrest, sometimes tubules with only Sertoli cells, or tubules with some amount of spermatogenesis. That is called mixed patterns. Sometimes we get mixed patterns also. So this is a picture showing maturation arrest. There is no evidence of spermatids anywhere. Only you're seeing spermatocytes. This is a picture for maturation arrest. This is also another picture for maturation arrest. See, you don't see spermatids at all. You see only the spermatocytes and lining Sertoli cells. So what are the causes? These also similar causes, again, exposure to chemicals, chemotherapy, genetic causes like androgenital syndromes, mumps orchitis, endocrine causes, spinal cord injury, etc. The causes are similar, but the pathology is different. Now coming to Sertoli cell only syndrome. So Sertoli cell only syndrome, as the name indicates, the tubules are lined by only Sertoli cells. There are no germ cells at all. Not a single germ cell is present in any of the tubules. This is also called germinal aplasia or Del Castillo syndrome. So there is no germinal epithelium at all. And these are small tubules lined by Sertoli cells which appear perpendicular to the basement membrane. There is no evidence of fibrosis. Leydig cells number may vary. So let me show you a picture. So this is a picture where you see only Sertoli cells. I'll show a more clear picture. This is a very clear one. There is no evidence of spermatogonia or spermatogenesis at all in the tubules. Only there is a tubule. There is a line by these Sertoli cells. So this is Sertoli cell only syndrome. The causes, again, there can be exposure to chemotherapy, the genetic causes, uremia, orchitis, etc. Similar causes that also lead to the Sertoli cell only syndrome. Then coming to mixed patterns. So there will be two population of tubules. Either there will be tubules showing only Sertoli cells or some tubules showing reduced spermatogenesis. One tubule may have both changes also. In these types of patterns, if the tubules are showing some showing spermatogenesis, some showing only Sertoli cells, or some show only hyalinization, we call it as mixed atrophy. Then we give the impression as mixed atrophy. Then this is the example. See, you can see one tubule here, only Sertoli cells, but some tubules are showing spermatogenesis. So this is a mixed pattern. Then infertility associated with hyalinization. So there is peritubular fibrosis and tubular hyalinization. This happens when there is long-standing damage. So there is fibrosis interrupts the blood supply and the tubule gets totally hyalinized. I'll show you a picture. This is another picture showing total hyalinization of the tubules. You don't see even Sertoli cells. You just see the basement membrane and hyalinization of the tubule. The common cause is, again, the same causes, but sometimes in postpubertal androgen or estrogen excess, we see this hyalinizations. Even in the cryptorchid testis also, if it is damaged to totally, it will give rise to total hyalinization of the tubules. And coming to semi-quantitative analysis, so how do you quantify the spermatogenesis? The quantification of spermatogenesis is usually done by the Johnson grading, modified Johnson grading. Each tubule is assigned a value and you grade it from 1 to 10. So all tubules have to be evaluated and you give a mean value for in the diagnosis. So what is the scoring system? This is all there in your textbooks also. It is grade from 0, this is to 10. 0 is no cells at all in the tubular sections. 10 will be normal spermatogenesis with many spermatozoa in the tubule. In between, you have the varying degrees. Like in grade 1, it is no germ cells, only Sertoli cells. In grade 2, spermatogonia are the only cells present. In grade 3, only few spermatocytes, less than 5. And then later it is more, 5 to 10. And finally, more spermatozoa. So 1 to 10. So mean score should be at least 8.9 and 60% of the most tubules should score at least 10. So how do we also can enumerate ratio of the germ cells to the Sertoli cells. So the germ cell and Sertoli cell ratio should be counted in at least 30 tubules. The ratio is usually 13:1. That is, there will be 13 germ cells for one Sertoli cell in young healthy men. So this is used in this Silber-Rodriguez-Rigo method. And sometimes we also measure all the spermatids which are present in the tubules and express them as a concentration of number of spermatids per tubule. This can compare with the sperm count with the amount of spermatogenesis can also be done. In intratubular germ cell neoplasia, that is this carcinoma in situ cases. In postpubertal patients, most commonly the germ cells are in these patients, they show the cells are enlarged with hyperchromatic nuclei and there is increased mitotic figures. And certainly cells are displaced towards the lumen. Spermatogenesis is not seen in cases of intratubular germ cell neoplasia. There will be no spermatogenesis or spermatocytes at all. There will be some thickening of the basement membrane, and antibodies to placental alkaline phosphatase are very specific to these intratubular germ cell neoplasia cases. And also I said nowadays we also use IHC marker OCT3/4 to diagnose carcinoma in situ cells. This is a picture showing the carcinoma in situ cells. You see the very hyperchromatic pleomorphic nuclei. There is no evidence of spermatogenesis at all. This is the intratubular germ cell neoplasia. And this is the PLAP stain showing all these cells stained with this nice color. And coming to cryptorchidism, cryptorchidism is arrest in the development of germ cells. There is hyalinization and thickening of the basement membrane of the tubules. And we have prominent Leydig cells. There is Leydig cell hyperplasia in cryptorchidism. So this is a case where you can see there is no spermatogenesis at all. And you see this Leydig cell hyperplasia in the stroma. In torsion, other uncommon causes we see is torsion and infarction. We don't do a typical testicular biopsy because if torsion lasts for more than 24 hours, the testis is almost becoming an infarct. But up to 6 hours of torsion, we can check for viability of the testicular tissue before doing the surgery. So these are the changes you will see from no nuclear pycnosis to infarct and granulation tissue in cases of torsion and infarction. This is a picture, histopathological picture in torsion. Then coming to uncommon causes like microlithiasis, I have told you on ultrasound, if you find microlithiasis also, we can do a testicular biopsy. Only when there are at least 5 foci of calcification, a biopsy is warranted. Large majority of cases, they are not associated with any germ cell malignancy. This is the histopathological picture showing some calcifications in this is the calcification in the seminiferous tubules. Another uncommon cause is vasculitis. Vasculitis where painful enlarging or shrinking testis And this, it will show on histopathology, vasculitis features, that is the blood vessel surrounded by these inflammatory cells. Other uncommon cause we can see is amyloidosis. Amyloidosis, systemic amyloidosis also involves testis, and amyloid deposition occurs in relation to the blood vessels of the interstitium and walls of the tubules. So what is new in this testicular biopsy? So all these days we were doing testicular biopsy as a diagnostic, invasive diagnostic tool for evaluation of male fertility. But now it is also a treatment modality for male infertility. How it is a treatment modality? We are using testicular biopsy to harvest sperms, or sperm retrieval technique is the latest in testicular biopsies, assisted reproduction. That is, this is terms testicular sperm extraction for IVF, where we do intracytoplasmic sperm injection. In these cases, the success rate of retrieval is around 63%. So this is the latest in cases of as a treatment modality for male infertility cases is these intracytoplasmic sperm injection. And this is sperm retrieval is done using testicular biopsy and preserving them in cryo for further IVF uses. Okay, that is the end of my topic. Thank you. Any questions regarding this?
Yes, ma'am. Yeah. So the first question is how to calculate residual cytoplasm droplet, and what is the normal percentage of residual cytoplasm droplet?
I didn't get you. Residual cytoplasm of what?
So the question came as this: how to calculate residual cytoplasm droplet?
No, I'll have to read about it and find out. I haven't reported any case like that.
Sure. And the second question is how to differentiate WBCs and immature germ cells microscopically?
That is probably for semen analysis.
Microscopically, ma'am. How to differentiate WBC and immature germ cells?
Oh, in the testicular biopsy?
Yes, yes, ma'am. Yeah.
No, germ cells, WBC will be, okay, you say lymphocyte. For them, for the lymphocytes. Lymphocyte have more even chromatin. Here you will see if you go into the previous pictures, the chromatin pattern is different. And they are not uniform at all, the spermatogonia. They're of different shapes and sizes. Whereas if you go into lymphocytes, they're all of the same size.
Yes. Yeah, ma'am. Thank you, ma'am. And hope Dr. Krishna Chaitanya, sir is, eager to answer this question. Can I mute Dr. Krishna Chaitanya? Just a minute.
Yes, Shakti, you can unmute him.
Hi. So I think there are two questions which, the residual cytoplasm, how much should it be? So, in the process of spermiogenesis, that is the last event where the round cell becomes an elongated spermatid or a spermatozoa, the residual cytoplasm should go. If there's persistence of residual cytoplasm, that indicates that the sperm might have oxidative stress and DNA damage. So there are reports which say 14%, 10 to 14% is what is normal. Anything more than 10 to 14% is considered to be abnormal. So that is something that we need to keep in mind. So when you're doing a normal pap smear staining for morphology, you'll have to count in those 100 sperms, how many sperm cells do have this residual cytoplasm. So that was question number one. The second one, how do you differentiate between the WBCs and the germ cells? I think peroxidase staining is the staining method that WHO recommends. It's a very, very easy test to do. And when you do the peroxidase test under the microscope, the WBCs are going to look brown in color. So all the brown cells will be WBC. It's quite a cheaper test to do. It's not very expensive to do that. So in our practice, what we do is when we see a lot of round cells in the morphology slide, we then do a peroxidase staining method and we count how many brown cells we're seeing per high power feed and we report it. Hope that answers the questions of the audience.
Yes, sir. Yeah.
Thank you. Thank you.
Thank you, sir.
I didn't know.
Yeah. Thank you so much, sir. So, Madam, one more question. At what count semen fructose test is recommended?
I think it's for semen analysis.
Semen analysis.
Again, fructose is more of a functional marker for seminal vesicle. So there's nothing like if you see sperms, that's it. You don't really have to do it. It's all about presence or absence of seminal vesicle. So can we quantify it, and does that have any prognostic indicator? The answer is no. And fructose, even now we do it, but it's with the development of a lot of radiological investigations, especially transrectal ultrasound, where you could image the seminal vesicle. The role of quantifying fructose is no longer helpful in clinical management. So, absent fructose means that there's a pathology with the seminal vesicle, which is going in favor of non-obstructive azoospermia. That's what is the clinical significance. Beyond that, you will not have to dissect that information. And I think somebody has asked for necrozoospermia, what is the reference values? So, there was a point where we all misunderstood or mistook necrozoospermia as 100% immotile. But now I think referring to the 5th edition and even the 6th edition is taking 58% alive cells and 42% dead cells. So anything where the viability goes less than 58%, we need to be labeling the diagnosis as necrozoospermia. So sperm viability less than 58% is necrozoospermia.
Okay, sir. Yeah. So that should have answered the question there. So thank you, sir. Thank you for your answers. And we would like to move on to the next talk. So I would like to welcome my own friend and young and energetic radiologist, Dr. Sunit. So he is presently working as assistant professor in ESIC Medical College, Hyderabad, under the radiology department. And he has done his MBBS and internship in Usmania Medical College, post-graduation in Gandhi Medical College. So few research studies of his credentials were role of imaging in the management of intracranial lesions in HIV seropositive patients, role of MRI in the evaluation of cellular and paracellular masses, and MRI features of spinal tuberculosis. And he has various publications for his credits. So over to you, Dr. Sunit.
Sir, can we start?
Yeah, Sunit. Yeah, Dr. Sunit, you can go ahead.
That's fine. Thank you. Good afternoon, everyone. My name is Dr. Sunit, and today we're going to discuss about radiological investigations in male infertility. The aim of imaging would just to have three things. One is to identify the condition, select patients who are suitable for assisted reproduction techniques, and to determine the approach for genetic counseling to safeguard the health of future offspring. Imaging plays a very critical role in the identification of correctable causes of infertility. So as in with any condition, we have to have a systematic and structured approach, which would include history, physical examination, laboratory evaluation, and imaging. being a radiologist, I would like to have all things in my hand, the history, the physical examinations, the lab reports in my hand before I go for imaging, because that would give me a better idea as to what I'm dealing with. This is just a pie chart which shows what are the scenarios which cause male infertility in a patriarchal society like India, wherein female is always the culprit. 30% of infertility is basically because of the male factor, and the most common condition is varicocele, followed by idiopathic cryptorchidism, testicular failure, and semen disorders. Conditions which can be diagnosed radiologically, it's better that we divide them into pre-testicular, testicular, and post-testicular causes. So the pre-testicular causes are basically endocrine disorders, which include primary hypogonadism like Klinefelter syndrome and secondary hypogonadism like Kallmann syndrome, and pituitary gland disorders, like adenomas and infections. For testicular causes.
Yeah. Mataji, I think I'm done with my previous chapter questions. No, do I need to join?
Yes, ma'am.
Dr. Ratna, madam, can you please mute yourself?
10 chapter questions you have already done.
Yeah.
Dr. Ratna, madam, can you please mute yourself?
Because I'm having parallelly another CME webinar going on. So.
Dr. Ratna, madam, can you please mute yourself?
Otherwise, I wanted to leave Mother.
Madam is muted. That's so good. Okay, so testicular causes include varicocele insufficiencies like cryptorchidism and small size cysts, orchitis, torsions, and everything. In fact, Madam, the previous speaker has actually discussed at length about regarding these few things. Very grateful to her. Obstructions in major genital tracts would include epidermal, basal, ejaculatory duct obstruction, cysts, and erectile dysfunction as well. We also have to, let's go to imaging modalities, and the ones which we routinely use are the ultrasound Doppler of scrotum and testis, followed by transrectal ultrasound, which is not only used for diagnostic but as well as therapeutic things, and MRI. There are few other old diagnostic procedures like venography and vasography, which are not being used right now. Vasography, we use it with thrust-guided seminal vasography. The role of X-ray is limited. It's just used for testicular venography and embolization, which is a therapeutic procedure. Venography was regarded as a gold standard for diagnosis of varicocele, which you can see down, but this has now been superseded by Doppler as well as MRI. So this is an X-ray of seminal vasculography. It's an obsolete procedure, to be very frank. Let's start with ultrasound, which is the basic test which in radiological evaluation of male infertility. What we have to look for in ultrasound is paratesticular evaluation, testicular evaluation, and the evaluation of the seminal vesicles and ejaculatory ducts. So varicocele, it forms approximately 80% of men with secondary infertility, and it causes a progressive decline in fertility. So does not predict the resistance to varicocele in induced impairment of spermatogenesis, and it's better that men with varicocele have a prophylactic varicocelectomy to prevent future infertility. As you guys know, varicocele is just defined as dilated internal spermatic veins greater than 3 mm, and unilateral varicoceles are more common on the left side. Right varicoceles, if detected, should always be evaluated for any retroperitoneal tumor which happens in the abdomen. So this is a little busy slide, but it covers all the diagnostic radiological investigations for varicocele, which include ultrasound, which shows torches, tubular structures, or prominent veins in the pampiniform plexus. Doppler shows reflux in spermatic vein, and this is a simpler grading, I guess, which I guess should be used, but we do have many other gradings as well. So static is grade 1, intermittent being grade 2, and continuous reflux is in grade 3. Venography, as I told you, was done previously. It's just the enlargement of internal spermatic veins with reflux into the abdominal, inguinal, and other veins. MRI also shows varicocele in delayed images, delayed intravenous venous images. Scintigraphy is done, but I wouldn't give much importance to that. So this is the basic one. Like this is ultrasound, which shows the first 8 shows dilated tubular structures in the left side. And when you put in color, you have which shows up color uptake. In fact, what you can see here is just color uptake inside the varicoceles. But when the patient does a Valsalva maneuver, you have reflux. So the blue ones have become red. So that shows that there's a reflux inside the pampiniform plexus of veins. There's something also called as intratesticular varicocele. The previous one which I showed you was an extratesticular varicocele, but if you have seen, this is called as an intratesticular varicocele, that the veins are also dilated inside the testis. There is a common differential diagnosis for this, which is nothing but the tubular ectasia of the testis, which is just down, which is looks something kind of a fishnet kind of appearance. If you can see, when you throw color on this does not take up any color. So this says that these are seminiferous, these are just the tubules, seminal viscous obstruction. Because of seminal viscous obstruction, you have the retidestes which are enlarged. This is a selective venography of left testicular vein, demonstrates the dilatation of pampiniform plexus. And the MRI as well, we don't generally do MRIs for varicocele, but coming to this, we just have to show you that there are some tubular structures here, which are diagnostic of left-sided varicocele, and this can only be done in a post-gadolinium delayed images, because this being a venous pathology. Cryptorchidism, whenever we do not see a testis in its normal location, it's always imminent that we have to go through the normal descent pathway of the testis, and we have to find the testis. If we cannot find the testis, then maybe look at other ectopic sites like the thigh and everything else. So this is a 34-year-old man with bilateral cryptorchidism. The normal volume of the testis is somewhere around 18 to 20 ml, but let's give it 15 ml or something, but this is hardly 2 to 3 ml, and it was in the inguinal canals. When we did an MRI, this is what we found, the inguinal canals. You're seeing the testis here and the testis here. So cryptorchidism, if you leave cryptorchidism, let it be, and it runs its course, that the patient is an adult then. What happens is the antecedent testis becomes hypoechoic, it becomes small and becomes infarcted, and it would be of no use. So this is a 28-year-old man with a history of left cryptorchidism after orthopexy at the age of 6 years, but this right testis is fine. The left testis was cryptorchid, but it was orthopexy was done, but still it looks markedly heterogeneous and small. Epidermolysis is the inflammation or infection of epidermis and testis, and when you compare it with the grayscale image, and we put in color, the A and B are grayscale images, which can see that the testis is markedly enlarged, with the epidermis also being enlarged, with it being hypoechoic, and when you put in color, it shows up beautiful color uptake. The same epidermolysis is just infective epidermitis here. You can see that the epidermis is enlarged. Why is infection needs to be diagnosed? It's pretty simple. There are two things. Number one, it's easily treatable, cause of fertility. Number two, with broad spectrum antibiotic studies. Number two, there's a chance that this infection might spread to the female counterpart during intercourse, and this might cause infertility to the female as well. This is testicular erosion. If you can see on the right side, let's say it's on the left side of the screen, that's for left side of the screen, you can see that the testis shows color. On the right side, it is markedly hypoechoic. That means it is it's markedly darker than one on the right side, and there is no color uptake. The ones which you're seeing there, that right thing is just the artifacts which you're seeing. So that's the normal versus chronic infarcted testis. So once the testis goes into torsion, it goes into infarction, the size decreases, there's no color uptake, it becomes markedly heterogeneous. So the A image is the one which is normal testis with normal color uptake, and the chronic infarcted testis, as a chronic condition B, would be small, would have heterogeneous ecotexture, and would not have color uptake. Testicular microlithiasis, the speaker before me has already discussed regarding this. This is diffuse testicular microlithiasis, and we have multiple tiny microcalcifications. It's said that the calcification of the seminiferous tubules causes male infertility. You also have a seminoma here, testicular mass showing up color uptake. Sometimes two conditions can coexist at once. Madam has said that microlithiasis going into seminoma is really rare, but sometimes you do have two conditions at one point, which is microlithiasis in this, the arrows point towards microlithiasis, testicular microlithiasis, and a biopsy-proven seminoma. After the testicular causes, we have to jump into the post-testicular causes, or paratesticular causes for that matter. And this is a normal testis. Normal one shows normal epididymis and the normal testis. But if you can see here, they are dilated small tubules here. So this is just the epididymal tubular ectasia in a patient of post-vasectomy status. The same thing you can, whenever if there's no palpable vas difference on physical examination, you can see the dilated retitestis on both testes. Sometimes two conditions can coexist at once. So this is tubular ectasia of the retitestis. That's the normal testis, and the arrows point towards the dilated retitestis, and this is the dilated tubules in the epididymis. Two factors at once again. This is A is varicocele and B is epididymitis. So the patient is having varicocele with an infection. Sometimes impotence can also happen, and Peyronie's disease, this being patient having painful erections with infertility, and there is a palpable abnormality along the shaft of the testis, where this is the ultrasound which shows the calcific plaque. Post IV contrast, you can see that there is a mild enhancement of the calcific plaques. This is axial section and a sagittal section, showing there is an enhancing plaque on the anterior aspect of both cavernosa and the posterior aspect of the left corpus callosum. Impotence can also erectile dysfunction, or can also be diagnosed on a penile Doppler with the peak systolic velocity of cavernosal artery being less than 25 centimeters per second post 15 minutes. If you can see, this amounts to around 10 to 15, so that would go to erectile dysfunction, and end-diastolic velocity less than 5 centimeters per second would go for venous insufficiency. TRUS is also done, which is transrectal ultrasonography for the evaluation of ejaculatory duct obstruction. Just as in case of females where a TVS is done for uterus and ovaries, TRUS would give you much information. It will give you better information regarding will give you better evaluation of the prostate, as well as other abnormalities around the prostate, like prostatic cysts, Mullerian-Wolffian duct cysts, and seminal viscography can be done through a TRUS. So this is a normal TRUS. Let's look at the normal ones first and then go to the abnormal one. So this is a normal TRUS down. The prostate is normally seen. And when you see here, there's a ejaculatory duct calcification with the dilatation of vas difference, the long arrow. There's a dilatation of vas difference. This is a vas difference which is dilated. Now it is now thickened, and you have multiple calcifications in the seminal vesicles and vas difference. Abdominal ultrasonography also should be done in cases with vasal agencies, because there is associated renal anomalies. Let's go to MRI, which is goes for central causes. Central causes, prolactinoma is one cause which can cause infertility. Most of the times it's macroadenoma, but yeah. If you can see here, it's a 26-year-old man with elevated prolactin level. So this is an axial T1 section. That's the small thing there which is T1 hypointense, and it's T2 isointense, but you can also see something which is T2 hyperintense here. Post contrast, there's enhancement of that lesion, if you can see here, and there's small central hypo or black thing, which is indicative of necrosis. Microadenoma, as you can see, this is a T1 pre-gadolinium phase, and post-gadolinium it is enhancing. So microadenoma causing in male infertility. As I told you, MRI has now superseded for X-ray procedures, and it's the same case here. You can see that there's a prostatic cuticle cyst with multiple dilated seminal vesicles. During a interventional procedure, a cyst will now be ruptured through this, and then it can be taken care of. Proceeding with cyst, this is a prostatic cuticle cyst, which is T2 hyperintense here. We have a Mullerian duct cyst, which is showing shading would be because of hemorrhage within it, and a large seminal vesicle cyst, all causing male infertility. You also can diagnose seminal vesicle abnormalities or with an endorectal coil. That is, we put an endorectal coil, and then you can do an MRI, which shows in a hypospermic male, it would show normal left seminal vesicle here, as you can see on the left side, but on the right side, there is no seminal vesicle. So you can diagnose seminal vesicle abnormalities as well. In fact, after absence, you can also diagnose mega seminal vesicles, like in this case, wherein the seminal vesicles apparently are dilated here. And if you go up, these are all these cysts are seen in ADPKD. So the patient has ADPKD, autosomal dominant polycystic kidneys, adult polycystic disease, and with mega seminal vesicles. So a patient with cystic fibrosis, you can also have just a absent seminal vesicle, the rudimentary left seminal vesicle, and fatty replacement of pancreas. There's no pancreas is not at all seen here. Madam also touched on Kallmann syndrome. So first, let us understand what normal anatomy would be in Kallmann syndrome. Klinefelter syndrome would just have cryptorchid or just a small testis, which I've already discussed. But in Kallmann syndrome, you have something called as olfactory sulcus. This is the normal anatomy. The olfactory sulcus, the straight and the median orbital gyrus, and the olfactory bulbs. I'll go again. Olfactory sulcus, straight and medial orbital gyri, and the olfactory bulbs. Now let's go to the above picture, which shows olfactory bulbs. No olfactory bulbs here. The olfactory sulcus is absent, and the straight and the median orbital gyri are also absent. So this Kallmann syndrome can be diagnosed on a T2 weighted coronal image showing these. First, you have to understand the normal anatomy, then go to the Kallmann syndrome. So in concluding it, imaging plays a very key role in the evaluation of hypospermic or azoospermic male. It can detect corrective abnormalities like varicocele or infection or anything else. And it can also reveal potential life-threatening disorders like seminoma in the course of infertility evaluation. Thank you so much.
Thank you, sir. Thank you, Dr. Sunil, for your elaborative presentation.
Thanks so much.
Any questions from the participants? Any queries are welcome.
Thank you so much. Thank you for your patience, everyone.
Thank you.
Thank you, Dr. Sunil.
We are now moving on to the next topic. It's my great pleasure to introduce Dr. Krishna Chaitanya, who is a scientific director at Oasis Center for Reproductive Medicine, Hyderabad. He has done his MBBS from Rajiv Gandhi University, Bangalore, and postgraduate diploma in reproductive sciences from Monash University, Australia. Masters in clinical embryology from Monash University, Australia. At Oasis, his main areas of work are cryobiology, in vitro maturation of oocytes, andrology, and men's health. Currently, he is working on employing newer techniques to improve the success rates of in vitro fertilization, PCOD, and recurrent IVF failure cases. Sir is going to deliver his talk on additional laboratory parameters for evaluation of male infertility. Over to you, sir.
Sir, over to you, sir.
So are you able to hear us? Sir, I think you are
Sir,
muted.
I think you are muted, sir.
Yeah, now I was not allowed to talk then, so I think that was the whole issue. Thank you. So thanks for that kind introduction, madam. I think somebody has to allow me to share my screen as well. Then only I'll be able to share my presentation.
We should start.
Dr. Ratna, ma'am? Yeah.
Sir, are you able to do it now? Sorry,
Yes, I'm able to do that. Are you all able to see my screen now?
Yes, yes, sir.
Yes, sir. Yes.
Wonderful. So I think, just not the advanced lab things. I tweaked the topic a bit to what are the recent trends that have changed in managing the male infertility. I think both the professor, head of the Department of Urology, and Professor Krishnakant wanted a bit elaborate presentation. So I'll touch a bit more on the recent advances that have happened. So now male factor is equivalent to the female factor when it comes to a couple's contribution. Gone are those days where we thought only the female was the reason for infertility and there was very little male factor infertility. Rather, I would say there are times where we see more of male factor infertility. So there's an absolute need to discuss more and intervene more. And I'm glad that the organizers thought of doing this session exclusively on male factor infertility. So, in the year 2022, at least, I think the beauty is to give a couple self-gamete conception. Probably in the early 90s or late 80s, when things didn't work, when technology wasn't that advanced, for azoospermic men or a lot of other situations where we were not able to do the ART procedures, we just used donor sperm. In the current day, I think donor is the last option that we could think of in a couple's infertility journey, and we want to move away from this concept. And there's so much more that the science and technology is offering us where a self-gamete conception is possible, and I'll elaborate in a short while about that. Now, what changed the way we practice male infertility in the present day is invention of this micromanipulation. So this is a setup of micromanipulation or the ICSI procedure. And with the invention of this is where we are able to treat male factor infertility efficiently. Even the testicular sperms can now be injected and we're getting pregnancies and live births. And there are several studies which have shown that there's no difference in the pregnancy outcome whether we used testicular sperm or the mature ejaculated spermatozoa. The technical know-how and the laboratory developments with the surgically retrieved sperms in the last 2 decades have improved so much that it has added on to a lot of success and the way we practice ART. Invention of cryopreservations. Now in the present day, we can freeze the eggs, sperms, testicular tissue, ovarian tissue. So that is again changing the way we practice fertility, and more so male infertility is developed because we can pull up cryptozoospermic samples. We can freeze the micro TC obtained sperm samples and then offer and do ICSI on them. There's so much that's improved and developed with the culture systems, the knowledge of how to handle the gametes and embryos and optimize the reproductive outcomes has really gone leaps and bounds in a different direction, and that has helped us get the best outcomes. A lot of reproductive genetics is another important thing that's recently added on in the last decade. A lot of work that has happened and added on to our understanding of what causes the male factor infertility and how do we efficiently manage and deal with it. So that brings us to our today's discussion. What are the latest trends with managing the male factor more so on the laboratory side? So first question, is there a need to look at further advances or some additional tests? The answer is definitely yes for that. The WHO-based semen analysis doesn't really give us a proper insight or a true fertility status of a couple's infertility. We need to make a note that it is just a screening test and not a diagnostic test. It only tells us a range and we will have to go ahead. There are a lot of times people come with several reports and they're debating on it as there's so much of fluctuation. We've seen normal reports in the past. Why is it that your lab has reported totally different or an abnormal report? And we all know there are several reasons, and semen analysis, in spite of scientists bringing in computer-assisted semen analysis, which was an attempt to automate semen analysis and remove the human error and human element, I think we're still not successful. computerized semen analysis is still not a routine clinical practice. It's got a lot of flaws with it. I think we still go with a manual method, and that isn't a true status of a man's fertility status. So there has always been a need for doing some kind of advanced sperm functional tests or assays. We could discuss and debate on that for almost a day. But of the various list of tests what we have, looking at sperm's DNA fragmentation is what is thought to show some kind of clinical correlation. And there's a lot of research that's gone into this. It is shown that sperm DNA fragmentation can bring about suboptimal embryo development, recurrent implantation failures, miscarriages, and usage of such sperms could bring about epigenetic changes. And there's also a hypothesis that using such sperm where the DNA fragmentation is there could be a factor to bring about some kind of placental diseases or issues in the future, which is still a matter of debate, needs a lot of research to validate that. But the point is, if a sperm has got a fragmented DNA, it can influence and negatively bring down the reproductive outcomes. And currently, we could test it and go about with the management. So that's a recent guideline for good practice, which was published recently by Sandro Esteves group from Brazil. And for a very long time, we've been questioning the role of DNA testing and doing some kind of clinical application or intervention. And this recent guideline tells that how and when do we do the sperm DNA testing, indications for testing, and the level of recommendations for each of them. This is free to download, available in Google. You could go, and I'm more than happy to share a copy of this if somebody is not able to download it. I'll not get through details of it, but sperm DNA fragmentation, right now, I think there is a level B2C recommendation for us to test, and we are also aware of the indications. So that brings us to two main ways of treating. So there are a set of people who think that we should need to treat the man first and then see what happens and then go about with the treatments. There are a group of people who say treating the man has not been beneficial in the last few decades. So should we be treating the sperm directly? So let's have a bit more of insight as to how this all can be done. So first question, why do we have to treat the man? There's so much of work that's happened to say that oxidative stress is one of the primary reasons why there is male factor infertility, and treating them with antioxidants or treating the underlying cause to bring down the oxidative stress can be an efficient way, and a lot of focus on these environmental issues that could bring about epigenetic changes and more harm in the future is something that we all are worried about. So bottom line, I think treating the man seems to be a beneficial thing. So what are the options? We either give antioxidants, which we all know, or we treat the underlying cause. So untreated diabetes, untreated hypertension, varicocele, genital tract infection, certain medicines we all know that could cause it, so you treat that cause. Or a simple thing of daily ejaculation has shown to improve the sperm's motility and DNA quality. Or finally, the recent one is to do a testicular sperm aspiration. We all know that TISA has only been done for azoospermic individuals to know whether sperm is there or not. But this is a new indication where we do a sperm retrieval from the testis. These men are not azoospermic. It's because there's DNA fragmentation that's on the higher side. We do it, and that has shown to give beneficial outcomes. So that is what we do at Oasis. We believe in Oasis doing testicular sperm aspiration for men with raised sperm DNA fragmentation. And this is a 10-year data of Oasis that was published in Fertility Sterility in the year 2019. And we've shown that these are people with failed implantation. They were not pregnant with the first IVF cycle. We did a DNA fragmentation, it was raised, hence we did a TISA. 36% men still managed to have a live birth rate. From 0%, with this intervention, it's gone to 36%. So it is something that is worth considering. We also were worried to see if testicular sperm versus the ejaculated sperm, would there be a difference in the reproductive outcomes? And this again study got published in Fertility Serenity. This is 10 years data of Oasis fertility. And we found there was no difference in the live birth rate between the ejaculated sperm, which is more thought to be more mature, versus the testicular sperm, which is considered to be mature because it has not completed the whole process of spermiogenesis. We also looked at the maternal outcome, the perinatal and neonatal outcome, and we wanted to see if there was any added incidence of congenital anomalies with the testicular sperm conceived children. And we did not find any statistical significance. And this study we published to impress upon everyone that testicular sperm is safe, the science is changing, the way we practice needs to be now changed. And that was about treating the man. Now, what are the options that have come? There's so many added interventions that have come as to how do we treat the sperm. So we all know that sperm processing is done by gradient processing, a double density gradient processing. But there's so much more that in the recent times we have seen scientists doing a lot more advances. So magnetic cell separation, microfluidics, IMSI-PIXI. So these are different advanced procedures, and the aim and objective is to separate and provide us with sperms with good DNA quality. Each one has got a different methodology. I'm not getting the details of that, but the science of sperm selection is thought to be important, and there's so much of research that's gone, and all of this is clinically available. We can do it in Hyderabad, we can do it in ESI Medical College as well. There's nothing like only the Western world is doing all of these things. All of these are clinically validated and it can be used. It's absolutely easy to apply as well. So there is automation that has happened with sperm selection. So this was again data which was published in the year 2020 at the ASRM American Society annual conference, where we wanted to see if microfluidics as a new technology was efficient enough to offer good reproductive outcomes. And we had a good live birth and implantation and clinical pregnancy rate with sperms that were separated with microfluidics. And another study in the year 2017, where we looked at the role of magnetic cell separation to separate the sperms with good DNA quality and good morphology, was on MAX. And again, that showed a good live birth rates for us. So we spoke about how the trend has changed. The basic semen analysis is not giving us adequate picture of fertility status of the man. So the predictive power is not great. So there has been a need for advanced testing where sperm DNA fragmentation is now shown to be an important test. We spoke about how to do the test, a little bit about the indications, and then we spoke about intervening. We either treat the man or treat the sperm, and that is helping us improve the reproductive outcomes. So let's quickly put a little focus on management of azoospermia. What are the newer trends that we have seen? So with one semen analysis, never diagnose azoospermia. And when you don't see any sperm cells when you're doing a basic semen analysis, before reporting azoospermia, you've got to be centrifuging the sample. And then the final pellet, which is 0.3 or 0.2 ml, you need to assess the entire sample. Even if you see one or two sperms, the diagnosis is not azoospermia. In fact, it will be cryptozoospermia, and the management is going to change. So never diagnose azoospermia with one semen sample. There has to be at least 2 semen samples, which are done at least, they say 3 months, but the patient might get very stressed. So in a private clinical practice, we do it a month apart. And if it's azo, then we go ahead with the investigations. I think there's so much that is improved or added on with investigations. We all know in a case of azoospermia, we get the hormones, and if required, a transrectal ultrasound imaging. But nowadays, I think there's a lot of focus on getting a Y chromosome microdeletion. And it's more for a prognostic factor. If the Y chromosome deletion is in the A or B zone, there will never be spermatogenesis, and doing a TISA would not be helpful. And you could just tell the patient that the prognosis is not great, and they can straight away go for donor sperm conception or adoption. But if the deletion is in C zone, the probability of retrieval is higher, and we could do a testicular biopsy or aspiration. There's so much that is improving with the medical management. Even till today, the only FDA approved medical management is when there's hypogonadotropic hypogonadism. You give them FSH and then HCG and all of that. But is there a role to use letrose, clomiphene, and all of that? We will see how to go about with that. I think surgically, the micro-TC, which is micro-testicular sperm extraction or micro dissection of testes, when you use an operative microscope and then you dissect the testes deeper, that has shown to improve the surgical retrieval and then the reproductive outcomes. So medical management, if you test total testosterone, serum total testosterone, which ideally should be done at 8 a.m. in the morning. And the serum total testosterone has got a circadian rhythm, and sometimes it can vary if it is done by the end of the day. So get it done at 8 a.m. in the morning. That's one little thing that we need to remember when we are ordering the reproductive hormones. And if it's anything less than 300 nanogram per deciliter, we need to give them some kind of medical management, and use of HCG injections has shown to be beneficial. If there's somebody with non-obstructive azoospermia and you have a clinically palpable varicocele, the recent meta-analysis say that operate the varicocele, leave the patient for 3 months. When you bring down the oxidative stress, the spermatogenesis improves, and there is almost a 40% chance that you might get sperms in the ejaculate, or at least the surgical retrieval from the testes would improve. So there was a point where we said operating on a varicocele might not really benefit the patient. But again, meta-analysis are going back and saying if a non-obstructive or a severe male factor patient presents with a clinical varicocele, that is grade 2 or grade 3, it might be worthwhile operating. But again, the pros and cons, advantages and disadvantages should be discussed, because not every microvaricocectomy guarantees success. So it has to be taken with a pinch of salt, but there's definitely a role, and that's the recent guidelines which are coming up to operate before doing a testicular biopsy. I'll not get into the details of this because the head of the Department of Urology is going to deal with this, but micro-TESI is what is catching up. All that you need is a operating microscope, and the surgeon should be happy to dissect the testes. It definitely gives you a better success rates. Another thing that we all need to keep in the mind is fresh versus frozen TESA. The common practice is we send the patients to urologists. They do a trial biopsy and they send it for histopathology. The histopathology comes back as normal spermatogenesis. So what happens at this point? The patient gets referred to a fertility center. We need to redo the biopsy. But in the present scenario, you don't have to do that. Cryopreservation, freezing of the testicular sperm is absolutely possible. And this is our data of 10 years that we have published. Fresh testicular sperms or frozen testicular sperms, the reproductive outcomes, live births have been no different. So the technology is improved. Let's understand. So in the present scenario, if you're doing a testicular biopsy for a reproductive purpose, for infertility, you have to be freezing it if you've got sperms there. Not freezing probably is not going to be taken the right way. This, again, in freezing of sperm, there's so much of advances. This little device is called as a sperm VD device. It is manufactured by Israel company. So especially people like Klinefelters, or you've done a micro-TESI, and let's say we've got some 10 or 15 sperms, you can actually put it in those little circular areas, and you could actually preserve the sperms and do ICSI with that. And we have actually been doing this at Oasis, and we've seen wonderful success with that. The technology is improving. The lab side of the fertility has actually developed leaps and bounds, and it's really helped us offer couples with a higher percentage of success. So I think TESA, TC, apart from azoospermia, nowadays we've got an application which is different. So in cases with severe oligoacinterated or cryptozoospermia, you can do testicular aspiration, and that has shown to give a better embryo quality and implantation and live births. For raised sperm DNA fragmentation, sometimes we see that the genital tract infection keeps recurring. Even after 2 or 3 courses of antibiotic, they do not respond. And if that is causing a lot of DNA fragmentation, we can think of doing testicular sperm aspiration. For people with anejaculation or collection difficulties, there was a point where we said, there's no semen coming out. We can't do anything. Let's go ahead and use donor sperm and help the couple conceive. Right now, we can do a testicular sperm aspiration for these anejaculation cases and collection difficulty cases, and then go ahead and offer them similar success rates. So those were a few of the recent trends. Since I've got another 5 to 10 minutes left, I thought there's certain myths that have been prevalent in our practice, and let's see what the literature says, and let's take home some message for our clinical practices. So first, I think let's treat the woman first. If nothing happens, then let's involve the man. I think that's the concept of the past. So currently, we need to involve both the man and women together, and there's a good level of evidence where we say both need to be involved from day one. Without knowing what the semen analysis is, trying to give even folic acid to the female partner is not justified. And that is the paper which talks about the level of evidence being moderate, where both need to be evaluated together hand in hand. So the next thing is, man has got no age limit. It's only the female's partner where there's age limit. Again, this is a myth. Even men have challenges and concerns with the aging that's catching up. Yes, with women, the ovarian reserve is coming down quicker and faster, and there's a far more detrimental effect. But the same is happening with the man as well. We have seen in the history a lot of men at advanced maternal age. A lot of famous people have conceived children after the age of 55, 60, or even 70 at times. Even in the Indian, we recently saw a 72-year-old man giving birth, and we have heard several such stories. But what is the problem? The problem is not the man becoming azoospermia. Like menopause, where the ovarian production is diminished, that's not happening with man. It's the quality of sperm that's coming down. With the advancing paternal age, the sperm undergoes certain molecular changes. And when we do ICSI or some kind of ART, or we force a conception of such fathers who've got advanced maternal age, the children born out of this are prone for behavioral disorders. The incidence of schizophrenia, autism goes up by 50 to 80% in this children. So IVF, ART, and all of these conceptions or assisted conception is just not looking at success. It's also looking at the safety element, and it's important that we counsel people. So Indian Council of Medical Research recently, in the bill that was passed, which was the ART bill, has clearly put that men after the age of 55 should not be offered any kind of fertility treatments. And that's a law for us from this January. So we'll have to not offer treatments for people beyond 55 years. And we need to keep in mind, man is also aging. Andropause is something that's catching up a big time. Okay, there are so many times we get this question that semen analysis is teratospermia. Count is 100 million, motility is 40%, everything looks brilliant, but morphology is 1 or 2% because we're following the strict criteria, which is the Tygerberg-Kruger's criteria, where we're looking at multiple defects. So a lot of time people look at teratospermia and say that's the reason you're not conceiving. And there's enough evidence to say that isolated teratospermia, when count and motility is normal, just the focus and weightage on the morphology is not an indication to push the patient for IVF or ICSI cycles. The natural conception, IUI conception, is possible because of a mere teratospermia. It doesn't mean that the reproductive outcome is less, or the miscarriages are going to be more, or the congenital anomalies are going to go up. There is no such evidence anywhere in the literature. So isolated teratospermia should be interpreted with a lot of caution. A lot of counseling is needed to the couples who come to us where the report is teratospermia. Role of varicocele, we spoke in detail. I'll not get into this, but this is a wonderful paper which has shown through meta-analysis that 39% of people will have sperms in their ejaculate post-varicocelectomy. provided it is a grade 2 or a grade 3 varicocele. Again, a subclinical varicocele will not give us any benefit. So when not to operate for varicocele, if the semen parameters are normal, or it is a subclinical varicocele, isolated teratospermia, or there's an obvious female factor like a tubal factor, and you are doing IV fixie, again, operating for varicocele might not be the first choice. Genetics might not have a role. Genetics absolutely has a role in managing a male factor infertility, and the level of evidence is high. So all men who've got a sperm count less than 5 million and non-obstructive azoospermia, the literature, both the American and the European urology guidelines tell us that we have to get a karyotyping and a Y chromosome microdeletion. Both help us in prognosticating and managing the couple's infertility in a better fashion. Retroviral cases, especially if the couple is serodiscordant. Female is negative for especially the retroviral virus, and the man is positive. You know, we all thought that these people should not conceive. There are times where such couples were offered donor sample. But in the current scenario where the heart therapy is so developed, where we say putting empirical therapy to the woman, they can even have unprotected natural sexual intercourse and conceive naturally. So doing ART in such serodiscordant couple is absolutely possible. Till date, there is no report which has said that doing a IVF ICSI or IUI process for a serodiscordant process has left the woman turning seroconversion to positive or vertical transmission to the child. So that's again a myth. So because of viral infection, will the man have lower counts of motility is a point that still needs to be proven. But does that become an indication to offer donor sperm or adoption? The answer is absolutely no. Such serodiscordant couple can have their own genetic child. So people with collection difficulties, I think this is a bigger thing. You know, man is not a machine, and collecting a semen sample is an emotion. You know, you have hunger, you're going to eat. You are tired, you're going to sleep. So collecting a semen sample is also a similar emotion. And a man can find it difficult at times to masturbate and collect a sample. So just because there's collection difficulty, sending the man for usage of donor sperm is again not taken. And there are so many options that are available in the present scenario. Like, you know, you could do a TISA, you could do a vibrator. There is a whole segment of medical and surgical management that can be done. And as I told you, the whole concept is to give a self-gamete conception with their own DNA. So where do we use donor sperm as per the recent ICMR guidelines? Or what are those little important things? Donor program has to be anonymous. You cannot take a known donor. You can't have your friend, brother, cousin come and give a sample. So people who want to be a donor have to go to a registered, ICMR registered donor semen bank, and they need to follow that process. The samples are quarantined, frozen, and then only given. There are young donors, 35 years and less, and the indication has to be right, and the donors have to be properly screened. So the most important aspect with donor thing is they have to be quarantined, frozen sample. Fresh semen sample for donor insemination is an absolute no-no, and ICMR has made this a law through the ART bill in the recent time. So quick last 2 minutes as to where is the future going. I think there's a lot of focus on doing some prepubertal testicular tissue. We can freeze the testicular tissue, but what are we going to do that? Because we all know, especially in men, before puberty, there's no spermatogenesis that is happening. So freezing such testicular tissues, what do we do later with that is a lot of people in US and Europe are doing research, because these boys with cancer diagnosed in the young, there's where the prognosis is good. When they come to the reproductive age, they'll be azoospermic. So there is a lot of focus on fertility preservation for these young prepubertal boys. So I was just talking about this, you know, in the pubertal boys, you take it, you preserve it, but later can we transplant it back to the man's body and bring about spermatogenesis? It has worked out in the mice, but I think human experiments have not been successful. They're even trying this in the monkeys, rhesus monkeys, still not successful. creating sperms from stem cells. Again, this has been shown to be possible in rodents, but humans we yet to see. But if this happens, I think then every azoospermic man is going to have an answer for his infertility issue, and the usage of donor sperm or adoption might come down. So stem cells and sperms generation is another thing that's been looked in. Gene editing, we all know about the CRISPR gene editing and all. Well, at this point, it's sounding not very ethical, or there are a lot of challenges, but scientists have looked at these kind of gene editing where you could design your own child. I'm sure it's got a lot of challenges at this point. I'm not saying we got to be doing this. I'm not supporting or giving my idea here, but look where the science has changed. So when science has changed so much, we're still thinking about using donor sperm or severe male factor. The pregnancies are not going to be right. Let's not do it. I think we need to really come out of all of these things. So involve the man from the beginning. There's a lot of role to treat the man even before we offer any kind of fertility treatment. ICSI is not the only answer. There is a pyramid of options of medical management, surgical management. When nothing has helped, we then look at doing ICSI. Testicular sperm aspiration, or the whole concept of surgical retrieval, has improved so much. Do not do a teaser without having a frozen backup. A lot of fertility centers are more than happy to come and pick the samples after you've done a biopsy, and if there's sperm, they can freeze and they can later do ICSI. That avoids a man to undergo repeated biopsies. And the most important, donor is not the first option of conception when a couple comes to us for infertility treatments. So thank you so much for giving me that opportunity.
Thank you, sir. Thank you for demystifying various myths associated with male infertility and enlightening us on the novel sperm aspiration techniques and recent updates in the evaluation of male infertility. Thank you, sir. We are pleased to have you here.
Thank you, madam. But if there are any questions, I'll be more than happy to take. I'm sure I've got a mixed crowd, and it was a lot of advances that we spoke about, but at any point, anybody needs any kind of assistance or help or further discussions on this, from OSS, we'll be absolutely happy to give you that support.
Thank you, sir.
Thank you,
Thank
sir.
you.
Thank you so much. Yeah.
All right. Thank you, everyone.
I think there are no questions from the audiences. Let's move on to the next. Next topic is on semen preparation for IUI and IVF by Mr. Kamta Prasad. He has done his BSc Biomedical Science, MSc Human Genetics, and he is currently an embryologist, grade 1 scientist in the Department of Reproductive Medicine and Surgery at ESI PGIM SR, Basaidarapur, New Delhi. He has trained in embryology at Delhi and trained in andrology and CASA at Aurangabad. His field of interest is fertility preservation and pre-implantation genetic testing. We welcome you, sir. Over to you.
Thank you, ma'am. Thank you very much. Good afternoon, all. Today we are going to talk about the semen preparation for IUI and IVF procedures. Since for any procedure like in vitro fertilization, whether it is IUI or IVF, the sperm needs to be separate from the seminal plasma, which contains the inhibitory substances that might be affect the outcome of the results, whatever, whether it is IUI or IVF. The goal is to obtain a well sufficient, viable, and morphologically intact sperm for the insemination procedure. The procedure is to be quickly as per WHO within an hour it should be performed and separate from the seminal plasma to remove the dead cells, leukocytes, bacteria, contaminants that may be toxic to the oocyte or toxic to the even uterus while transferring by IUI procedure. So the benefit is again to isolate the eject spermatozoa, separate the debris, bacteria, viruses, antibodies, leukocytes, and the most important things, the prostaglandins, which cause uterine contraction after the transferring. It also allows us to resuspend the sperm in a particular volume that we want for insemination or the final use. The semen source can be ejaculated, that may be fresh or frozen. The electroejaculate, where there is difficulty in the semen collection. Vibration induced ejaculation, again used when there is a difficulty in sperm collection. Retrograde ejaculation, and surgically retrieved spermatozoa, whether it is from testicular or epididymal processes. So the standard method for isolation is here. The simplest method we can say is simple wash. Then the sperm migration based on the ability of sperm to swim up, the density gradient method, and some newer techniques like microfluidics, MAX are being added nowadays. We begin with the simple wash. So simple wash is recommended for a sample where there is a good concentration. If it is less than 20 million, that can be performed, and it is obviously free of debris. Leukocytes should not be there. In the process, we are diluting the semen sample with approximately double of the media. We centrifuge it, and the high yield of spermatozoa are isolated, which are going to be insemination, whether for IUI or for ICSI. This method is usually not recommended for IVF procedures because that may contain the viable sperm along with non-viable sperm that are sedimented beneath the tubes. So advantage, it's a simple and quick to perform. Only a single centrifugation is required. It gives high recovery of spermatozoa since all of the sperms are going to be sedimented, and require minimum processing of sperms as well. But there are disadvantages. Since motile spermatozoa are concentrated in the presence of dead sperm, white blood cells, and other seminal debris, which may expose sperm to the high level of reactive oxygen species that affects their function. And it is usually not recommended for standard insemination, as I said before. The other method is swim-up procedure. Swim-up procedure, it's depend on the ability of sperm to swim up. So basically, in such procedure, after liquefaction, we take a fraction of seminal fluid that contains spermatozoa in a tube and overlay with 1 or 2 ml of media and incubate it 45 degrees for approximately 60 minutes at 37 degrees centigrade. Most of the motile spermatozoa comes out in the interface of the media that have been layered. We take out that media and again perform a simple wash on that. So the highly motile spermatozoa was seen in the palate will concentrate according to the insemination volume and use it for the purposely. So this method is very cost effective since it involves only a single media. The high concentration of motile and morphologically normal sperm are isolated because that is entirely naturally depend upon the capacity of sperm to swim. No contaminants from non-germ cell debris and seminal contaminants because they're left behind, and it also does not require initial centrifugation, thus no exposure of ROS. But yes, there are disadvantages. The low yield of motile sperms, exposure of motile sperms to semen for a longer period of time because the incubation time is approximately 1 hour. During that time, they might be exposed to the toxic substance that is there in the seminal plasma. It also takes a longer time to perform. The other and third method is density gradient. Here we are going to discuss 2-layer protocol. So here we are using two different layer of media, and above that we overlaid the liquefied semen sample. We applied it for centrifugation, and most of the motile and intact, morphologically intact spermatozoa were passed through the layers of density gradient media and settle at the bottom. We further discarded the upper layers of seminal plasma and the two layers of density gradient media that can be 45%, 40%, 90, 80%. There's a combination. And after that, we perform a simple wash on the palette. Finally, we have a concentrated, good, intact, morphologically spermatozoa, which we can use for the either IUI, IVF, or ICSI procedure. And there are advantages of this. It completely filter out non-motile sperms, amorphous cells, WBCs, and debris. The final sample has increased percentage of motile sperms. It reduced the exposure of sperm to ROS. And there are again disadvantages. It involved more take time to perform, required special media, and only a fraction of motile sperms is recovered. May not be good preparation when sperm concentration is motility is reduced, because there are chances if there are some abnormality, they will stuck in the upper layer of density gradient media. The other and newer method is microfluidics, which is introduced in 1993, that are in combination of silicon or glass microfluidic devices. They also allow a sperm to separate from the allow a motile sperm to separate from immotile sperm and debris to a separate column, so that they can be isolated and used for the further procedure. It has been found that the sperm that is being selected by microfluidic technique having the lowest DNA fragmentation index as compared to swim-up method or density gradient method. So it is simple and safe. Again, low level of DNA fragmentation have been observed, but the disadvantage is not capable of processing entire ejaculate, since only a fraction of sample is being used for sorting. It does not isolate all motile sperm. The other is Dr. Chaitanya sir mentioned that the preparation of virus positive specimen, most of the cases people denied that if there is a seropositive male. So there are procedures by which we can manage a seropositive male, because we know the HIV virus or any that can bind to the leukocytes or macrophages only. So by treating the conventional preparation method, we can process the semen. But yes, there are some questions that have been remain unanswered, whether that require a separate workbench, separate dedicated laboratory or facility for that, separate storage tank for frozen specimen. Is ICMR also in ICMR guideline, they indicate that the separate storage tank for frozen specimen that are seropositive is must for any clinic. So here are the flow by which we can measure the seropositive specimen. It is found that the level of the screening, after screening phase and sample collection, we have to do the double density. After that, we perform the swim up and make a 2 aliquot. The 1 aliquot is sent to the genetic laboratory for RNA testing or HIV DNA testing. If it is negative, we need to use the other sample that have been frozen at the same time. If it is positive, we need to discard both the sample and inform the patient, and also the immunotherapy has been recommended. Then what if we have the sample that are retrograde ejaculation? So here in ESI also we have managed a patient with IUI only. It was a first cycle where we perform the same method. We have neutralized or alkaline the urine by oral sodium bicarbonate, and then we'll process immediately. We'll transfer the urine sample immediately into the different test tubes, a set of test tube, then we centrifuge it. In the pilot, we add sperm wash media, so that the motile spermatozoa are concentrated. After the concentration of spermatozoa, we form the double density, and finally we did the IUI, which turns into a successful positive pregnancy and a successful positive delivery. What to do with the surgically retrieved spermatozoa? So there are various methods to retrieve the sperm. We have found that in epididymal they use, most of the sperms are found to be motile, while in testicular they are not showing the motility as initially, but after treating with some agents like pentoxifylline and all, we have found that there are slight motility which can be chosen for ICSI. So once the PISA or TC-PISA has been done, the sample is bring to the laboratory. We examine the presence for spermatozoa. We mechanically or chemically, mechanically or enzymatically treat those tissues so that we can isolate the sperm. Then again process it standardly. If it is epididymal, we can perform the number. If the number of spermatozoa are good, we can perform the double density. If it is not, we can simply wash the spermatozoa and freeze it or use it immediately for the ICSI purpose. So the conclusion is there are multiple techniques nowadays for preparing sperm for assisted reproductive technique, each of which has advantage and disadvantage. We need to choose the best one that is suitable for the particular sample or specimen. The method for sperm processing should be chosen based on the sperm concentration and motility, whether it is fresh or frozen or ejaculated or surgically sperm retrieved. Thank you. Thank you very much.
Thank you, sir. Thank you for your valuable insights. Any questions from the participants? So I think there are no questions.
Okay, thank you.
Thank you, sir. Thank you. So our next talk will be medical and surgical management of male infertility. For this, I am privileged to introduce to you all Professor Dr. Jagdishwar Tirukovela, who was born in 1960. Sir completed MBBS in 1983 in KMC Warangal and did his MS General Surgery from Usmania Medical College, MCH Urology from Gandhi Medical College. Sir has worked as Assistant Professor of Urology in Usmania Medical College and worked as Head of the Department Urology in Gandhi Medical College. After retirement, Sir worked as Professor and Head of the Department Urology in Kamneni Hospital, LB Nagar. From September 2021, Sir has been working as Senior Consultant and Head of the Department Urology in ESIC Medical College and Hospital, Sanat Nagar. Sir has 15 publications to his credit. Sir did basic and advanced medical education, served important positions of secretary and treasurer for various state level bodies in urology, conducted state and national level conferences. Sir has presented many papers, involved in debates and chaired sessions in various conferences. Sir, we are eager to listen to your talk, sir. Please take over.
Thank you. Thank you, doctor. Am I audible, doctor?
Yes, sir. Yeah. Yes, sir.
Yeah. Good evening, everyone. I don't know. It's 4 o'clock early. Good afternoon, everyone. And my talk today is medical and surgical management of male infant. Though I am a surgeon, the medical treatment also has been assigned to me. And in fact, much of my subject has been covered by Krishna Chaitanya, lessening my burden. This is, okay, then let us start. Okay. My talk is on medical and surgical management of male infertility. With modern technology and methods, the number of treatment options for male infertility have expanded. Depending on the cause of infertility, treatments may include the medical management, surgical management, or assisted reproductive techniques, in which I would get confined only to sperm retrieval techniques. About the medical management, we shall have to treat the infections, the seminal infections, taking the help of the culture and sensitivity, prostatic and seminal vascular infections, epidermal infections, acute and chronic, testicular infections, acute and chronic, and other infections, body infections. And treatment of the sexual intercourse problems like erectile problems. Erectile problems can be treated by means of medical means and many other methods. So they have to be dealt with. And then ejaculatory problems like retrograde ejaculation, anejaculation, and even premature ejaculation, all these have to be dealt with. Then neurogenic impotence and severe hypospadias can be dealt by means of IU. Coming to the other medical form of management is hormone therapy. Hormone therapy is to the causes like hypogonadotropic hypogonadism. And before going to the hormonal treatment, one should understand the feedback mechanisms of testicular function, that is spermatogenesis. And this is the age-old the diagram. You all know about it. Like the pituitary is controlled by hypothalamus, and then the gonadotropin is released by pituitary will be acting on the testis, FSH and LH, and then spermatogenesis goes on. Prolactin, when it's in large quantities, will be having inhibitory effect on the hypothalamus. This is about the hormonal function in spermatogenesis. About the FSH part of it, FSH is the best indicator of ability of the testis to produce the sperm. The high FSH is there, it is the testicular failure, and the low FSH is there, it is the pituitary gland dysfunction. This is a crude way we can remember this way. About the hypogonadotropic hypogonadism, we can treat it with a human chorionic gonadotropin, 1500 to 2000 international units thrice a week for 6 to 9 months. After 6 to 9 months, if patient remains azoospermic or severely oligospermic, one has to go for human menopausal gonadotropin or add recombinant FSH. Pulsatile GnRH treatment also can be carried out, which is delivered by in pulses using a portable pump. The same is a bit inconvenient to the patient. The other medications used in the hormone treatment are testosterone, clomiphene citrate, and tamoxifen. About hypergonadotropic hypogonadism, so in this testicular failure there of various causes, wherein one has to go for ART, that is artificial reproductive techniques, donor sperm or adoption. Then about hyperprolactin, whenever it is there, dopamine agonists have to be used to bring down that. For better fertility, one has to have a lifestyle modification like regular exercise and maintain low weight and quit smoking, limit alcohol intake, and avoid illicit drugs. And the regular intercourse around ovulation is which is advised. Hypergonadotropic hypogonadism, this we discussed. Yeah. Then other alternative drugs that can be used in fertility for fertility are L-carnitine, coenzyme Q10. These two are commonly sold by our companies in a very wide way. Vitamin C, E, and D, folate, magnesium, selenium, carotenoids, lycopene, fish, fresh fruits and vegetables. Others like ashwagandha, safed musli root, shatavari root extracts, conch-based seeds extract, so on. But one word about oxidative stress and antioxidant therapy. Infertile sperm cytoplasm contains low levels of scavenging antioxidant enzymes. So antioxidant scavenging antioxidant enzymes are very important. And when they are lacking, the sperm quality and the sperm other qualities would be coming down. And this, in fact, can be induced by many things like drugs, varicoses, smoking, pollution, cancer, and so on. And whenever antioxidants like vitamin E, folic acid, vitamin C, and the other things which I discussed just now are used, the sperm quality will be improving. These are all the various papers which indicate that the antioxidant usage improves the seminal quality. Like about one word about psychiatric well-being, like sexual counseling has to be done, in which sex education, planning of the sex, and overcoming the stigmata has to be done. Psychiatric counseling also has to be done for the family, And whenever some psychiatric disorders are there, these are likely to produce infertility and they have to be treated. Coming to the surgical management, part of it has already been dealt by Krishna Chaitanya. Varicocelectomy is one important surgical procedure in the infertility. Then the other operative procedures are surgery for obstructive agiospermia, that's vasovasostomy or vasal reconvolution, and vasoepididymostomy. Surgery on ejaculatory dysfunctions also is another type of procedures which are carried out. The sperm retrieval techniques are the ones which are useful for ART, that is artificial reproductive techniques. About varicocelectomy, this is most commonly performed surgery. 35% of the men with primary infertility and 80% of the men with secondary infertility do have the varicocele, and these varicocele cause poor sperm quality and poor sperm function and elevated oxidative stress and sperm DNA damage. So this DNA damage, whenever it is there, it will bring down the fertility. This we also know by means of DNA fragmentation indices. Decline in testicular function is duration dependent in varicose. For that reason, if you diagnose a varicocele to halt the further damage, it's better to go for earlier surgery. About the types of varicocele, we have a microscopic inguinal technique, inguinal subinguinal technique. This microscopic technique is the one which is more sought after, like it has more better results. Like in this, the recurrence rate is just for 0.5 to 1% only, and the other procedures are then little bit lesser than, but still better procedures. Laparoscopic varicocelectomy and conventional inguinal varicocelectomy. With laparoscopy, the recurrence is only 3 to 15%, and with same percentage of recurrence, open procedure, that is conventional inguinal procedure, is there. But when open procedure, the postoperative hydrocele formation is 3 to 30%. To bring down that in open procedures, you can go for simultaneous sac version of the tunica vaginalis. And about the laparoscopic procedure, 12% of post-op hydrocele is. In varicocele surgery, what is done is the pampiniform plexus cord is dissected and pampiniform plexus is exposed, and all the veins are dissected away from the arteries and they are ligated. One should identify and preserve the arteries. So if artery should not be damaged. Intraoperative microvascular Doppler is one instrument which would help in identifying the arteries. That way it will bring down the arterial injury, but it also improves our ligation of the number of veins, and it also prevents the ligation of the lymphatics. Lymphatic ligation is prevented, and artery injuries are prevented, and the veins, number of veins ligated will be increased, like improved upon. About the advantage of varicocele surgery is shown here, and whenever, even if ICSI is done in a patient who has varicocele condition, if it is treated, one type of result should there in ICSI, and not treated another type. For fertilization of the eggs, treated varicocele, 78% fertilization is seen, and live births are seen more in treated varicoceles in ICSI. And about miscarriage part of it after ICSI, less miscarriage is seen with the treated varicoceles than untreated varicoceles. About the sperm retrievals also, the ability of the sperm to be retrieved is better with treated varicoceles than untreated varicoceles. For all these reasons, even if someone is going for ICSI also, it is better that varicocele is treated. Coming to other types of operations, ejaculatory ducts and surgery on vas difference and surgery on epididymis. Vasovasostomy or vasal reconvolution is another procedure which is important procedure. It can be done by macroscopic means or microscopic means. And in this vasovasostomy, we have a crossed vasovasostomy or testicular transposition. Crossed vasovasostomy is usually done whenever the testis is good on that particular. If, for example, if you take right testis is good, but right vas is closed in its inguinal region, but lower down it is patent. And the left testis would be atrophied, and the left vas in the inguinal region is very much patent. So we can use the left vas for right testis. Right testis is dissected, the lower part, the proximal part of the vas, which nearer to the testis, is dissected, and it is transected and anastomosed to the left side of the vas. So likewise, the testicular transposition also, if it is on the same side, if it is not able to be brought down in position and say the other side testicle is atrophied, we take it onto the opposite side, and this particular vas is anastomosed to the other side. That's a crossed vasovasis. About the vasovasostomy and vasal recannulation, we healthier vas is after dissecting the vas difference, healthier areas are identified, and above and below of the obstruction they are transected. And once healthy transection is seen, then you map out the areas and you see that you put markers at see 6 places with equal distance, and they should be used for using the sutures like. And it is done in 2 layers. In the first layer, one can go through the lumen and inner muscles, and second layer, outer muscles and the serous layer. About the microscopic versus macroscopic, definitely, naturally, the microscopic vasovasostomy or vasal recannulation would be having better results. And the patency is supposed to be more with microscopic, and pregnancy rate also is supposed to be more with microscopic vasovasostomy or vasal recannulation. This already I discussed, crossed vasovasostomy and testicular, this is testicular transposition. About vasoepididymostomy, this is another surgery which is done, usually carried out whenever there is obstruction distal to the epididymis. We have end-to-side epididymis, vasoepididymostomy, and end-to-end vasoepididymostomy. Most of the times it is microscopy aided only. And there is another important type of vasoepididymostomy which is called as longitudinal intussusception vasoepididymostomy. Live, L-I-V-E, live. In this, what is done is the vas is, opened vas is intussuscepted into the single epididymal tubule, and the bites are taken much before the intussusception. Even on the epididymal tubule, first bites are taken, and then when the structures are being brought together, then an opening is made in the epididymal tubule. And this is a very leak-proof anastomosis done. Because since it is leak-proof and since the incision on the epididymal tubule is done just before they are approximated or intussuscepted into the epididymal tubule, the specimen or the fluid from the epididymal tubule can't be collected and can't be sent for examination. But still, the results are supposed to be better. For those reasons, this longitudinal intussusception vasoepididymostomy is more advocated. So here you can see A1 and A2, B1 and B2. Here B1 and B2 on the epididymal tubule. This is lower down is epididymal tubule. First bites are taken on the dilated epididymal tubule, and here they go through the lumen and they come out on either sides. And once they are being approximated and this vas is being prolapsed into, then the opening is made in the epididymal tubule and it is prolapsed inside and tight. So this is what is done. And here on the left side, we have end-to-end and end-to-side procedures of vasoepididymostomy. In long-term follow-up and results, naturally, I was telling that intussusception technique, live techniques fare better than the classical end-to-end or end-to-side. And the shutdown of the anastomosis in the long run is less with the intussusception procedure, that is live procedure, than the end-to-end or end-to-side procedure. With the live procedure, it's only 10% shutdown, whereas 25 to 30% is seen with end-to-end or end-to-side vasoepididymal anastomosis. Coming to the ejaculatory dysfunctions, we have dysfunctions because of the obstruction and because of without any obstruction. Obstruction, we treat them by means of surgery, whereas non-obstructive, these are all the causes, psychogenic causes, congenital causes, wherein prune belly syndrome and Wolffian duct abnormalities are seen. And then the neurogenic causes are there, wherein radical prostatectomy, bilateral sympathectomy, and any manipulative surgeries around the abdominal aorta damage the same sympathetic joint, that is abdominal aortic aneurysm surgery, para-aortic lymphadenectomy. They are all the causes, neurological, neurogenic causes. And the anatomic causes are transurethral resection of the prostate and bladder neck incision. They can produce that. And endocrine causes are hypogonadism causes. The other medicine-induced causes also are there: tricyclic antidepressant, thiazide diuretics, phenothiazide, and so on. Coming to the transurethral resection of ejaculatory ducts, TURED, which is done for the obstructive cause of anejaculation, like anejaculation as improper ejaculation, wherein here we resect the distal ends of the ducts, ejaculatory ducts. With this, the ejaculatory ducts get opened up, and the earlier before resection, before TURED, there must have been a painful ejaculation or hematospermia, which would disappear after this. And increased ejaculatory volumes are known to occur after this TURED operation. And improvements in semen quality also is known to be seen after this resection of ejaculatory ducts, transurethral resection of the ejaculatory. So as I told, pregnancy rate should be improving with post TURED, and semen quality naturally improves, which leads to this. And about one word about retrograde ejaculation. Less than 2% of the infertile men would be because of this cause. And in this condition, we will have to retrieve the semen that is deposited into the bladder after voiding and centrifuging. And then the same sperms can be utilized, provided it is done immediately after the ejaculation. And any time lag would be making the sperms to die actually. Sympathomimetic agents can be used to increase the bladder neck resistance. So normally whenever bladder neck functions, the retrograde ejaculation will be there. When bladder neck doesn't function and open between the ejaculatory ducts openings and the bladder cavity, nothing is there in between, there will be retrograde ejaculation. So any medicine that improves the bladder neck resistance would be giving the results. So anejaculation, non-obstructive anejaculation can be treated by other means, like one can induce ejaculation by penile vibratory devices, and if they don't work, then one can go for rectal electrodes and electroejaculations. But any condition because of the injury above the T6, this sort of electroejaculation should be deferred, because they are likely to induce autonomic dysreflexia and severe discomfort to the patient, and at times it may be detrimental also. These are the penile vibratory devices, and on the right side we have electroejaculation. Diagrammatically it has been shown, and the machine which is used for the electroejaculation is there at the right side. This I already discussed. Men with the neurological impairments in sympathetic outflow do not respond to vibratory stimulation, are subjected to this. Then one word about assisted reproductive techniques. Yeah, but this has already been dealt by means of Krishna Chaitanya. We have for sperm retrieval techniques, usually we go for retrieval techniques in obstructive conditions and non-obstructive. We have epididymal sperm retrieval techniques and testicular sperm retrieval techniques. In epididymal sperm retrieval techniques, we have macro technique and micro technique also. And likewise in testis also we have macro technique and micro technique. In epididymis, a percutaneous puncture can be made using a needle, which we call it as percutaneous epididymal sperm aspiration, that is PSA. So whenever we do it with the help of microscopy after incising the skin, we call it as MISA, that is microsurgical epididymal sperm aspiration. So this is PSA, wherein a 30 cc or 60 cc syringe is used and a negative suction is carried out after puncturing, and around 0.1 ml of epididymal fluid is obtained. Here the problem is there is likelihood of bleeding and likelihood of scarring. These two things can be there, which would not be seen with microscopic epididymal sperm aspiration. There is one thing called inverted motility, wherein usually in obstructions, the tail part of the epididymis will have better sperms, motile sperm than the head part of the epididymis. But whereas when chronic obstruction is present, the tail part will have a dead sperms, and little proximally in the near the head part, they will have viable and better sperms, which we call it as inverted motility. So this is about the MESA, which already I discussed. That's a microsurgical epididymal sperm aspiration, wherein a microscope, operating microscope is used, and dilated epididymal tubules are punctured or incised using a microscope. A single MESA procedure can yield a great number of motile sperms. As we said, better hemostasis is there with this, and the risk of scar is less. And whenever this MESA is done with a very small incision, it is called mini MESA. This is about the MESA procedure. Then TISA procedure. TISA means testicular sperm aspiration. Testicular sperm aspiration is done by a large diameter needles, which are passed from superior testicular pole obliquely downwards inferiorly, and then the aspiration is carried out. And once above the testis, this is an open, and whenever the tubules come out, you will be collecting them. This is called as TISA. Then another procedure is the TISA. TISA is an open procedure wherein the skin is incised and the testis is delivered, or testis is exposed, and then a 1 centimeter incision is given, and a fragment is excised with sharp scissors. And in that, the microscopically examination is done, and any sperms are there, they have to be used for ART, and they are preserved. Singular multiple specimens can be taken, and albumin incisions can be made in the upper, lower, or middle testis. So this is about the TISA. And then coming to the micro TISA, here also a microscopic procedure is there, wherein with the operating microscope of 10 magnification is used. Testis is not definitely bisected, but it is exposed, and the tunica albuginea is cut, and the testis is opened up, and to certain extent you open up the bisect the testis, and then the testis is examined with microscope. Thin white and stringy areas are Sertoli's only tubules. Sertoli cell only tubules means they don't yield sperms. Then the other areas, larger, plumpier and yellowish areas can be the yielding ones. They will contain active spermatozoa. Using the microdissection technique, from this larger, plumpier and yellowish areas, you should take the tissues and examine for the sperms, and you can use them. This is called as micro TISA. As Dr. Krishna Chaitanya said, this is the one which is being used more commonly these days. And he had a better diagrams actually. So this in the middle, you can see the plumpier yellowish areas, which are in fact engorged ones, distended engorged ones, so they can be used to collect the sperms. There is one more thing called percutaneous core biopsy, which is done with 14 gauge biopsy gun. Usually this may give rise to the bleeding or injury to the vessels, and epididymal injury also can be. For those reasons, this is not advised, but I mentioned it only for completion's sake. About the procedures that can be used, and all the epididymal procedures usually are carried out whenever obstructive element is there, but whereas micro TISA can be done even when obstruction is not there. And as Krishna Chaitanya sir was telling it, some of the syndromes also where even FST is a bit raised and all that, you can open up and make a trial of it. And in case any successful areas are seen, you'll be able to take the tissue from them and use for sperm harvesting. Thank you. This is about the medical and surgical management of male infertility. Thank you very much. Thanks for patient here. Any questions?
So thank you, sir. Thanks for enlightening us on the various medical and surgical aspects of male infertility with your depth of experience and wisdom, and for your enthusiastic participation, sir. Thank you.
Thank you.
Any questions from the participants?
More than questions, I would request Dr. Krishna Chaitanya to add, in fact, anything is maybe some deficiencies would there. I would be happy if you add some.
That was fantastic lecture, sir. I don't think I would want to add anything there. It was a very nice, journey through the whole surgical.
Thank you. Thank you.
I think our job gets easy if we have a surgeon like you, sir.
Thank you, sir. Thank you. Lena, good evening. So thank you, sir. Thanks for the organization. Thanks for the.
Thank you, sir. Thank you.
Yeah. Our next and the last talk of today's CME is setting up of IUI lab by Dr. Leena Wadhwa, who is in charge, a professor and in charge of Department of Reproductive Medicine and Surgery, ESI, Basaidarapur, New Delhi. Ma'am has done Foxy Ethicon Fellowship in the field of endoscopy, and she received Dr. Vasantben Shah Overseas Scholarship in Reproductive Medicine and Endoscopy from Bonn and Kiel University of Germany. She got trained in embryology from Chennai, and ma'am delivered Dr. Kamni Rao Foxy oration on maternal mortality at AICOG 2012. Dr. Leena ma'am was one of the editors for the book Current Concepts in Contraception and Women's Health. She has 45 publications in international and national journals for her credit. Her fields of interest are reproductive medicine and fertility enhancing endoscopic surgery. Over to you, ma'am.
Hello. Am I audible?
Yes, ma'am, you are audible.
Yeah, good afternoon, everyone. Thank you, Dr. Krishnakant, for the opportunity. And nice to hear the topic chosen is very nice, and it's a burning topic. And I agree with Dr. Krishnakant that male infertility, we had a visit from the headquarters in ESI Basaidarapur 2 days back. And we were discussing the occupational hazards which are leading to decrease in sperm count and increase in male infertility. So the topic is very apt chosen. And whenever we are planning the treatment, ultimately we need a IUI lab. So I'll be speaking today about how to set up a IUI lab. So can you please allow me to share my screen? It is showing host as disabled screen sharing. Or if there's any problem, you can project the slides. Yeah.
Is it okay, ma'am, now?
Yeah. It has come up. Okay, now I want to enlarge it, the screen. I think I'll just enlarge my presentation because it is not showing in full screen. Then I'll go for screen sharing. Yeah. Just a minute. I don't know, my presentation I'm not able to see, although I have enlarged it.
Ma'am, please click onto that.
Screen sharing?
No, you open the presentation, ma'am.
Yeah, my presentation I had open, but I'm not able to see. Can you project my slides if you have? Then I can speak on that also. Or Kamta has my slides.
Ma'am, can you please show me where exactly is your presentation on the screen?
Okay, I had opened it. I'll just see once again. Just give me time.
Yeah, ma'am.
I don't know where I'm not able to. Just give me a minute. I've shared it with Kamta. I'll just quickly go through it. I'll again open it then. Or if Kamta is there, he can just share it. Okay, I'm opening the PPT. Just let me know if it is visible. Yeah, is it visible now?
Yes, ma'am. But yeah.
Yes, ma'am. Yeah.
Yeah, is it coming full screen?
Yes, ma'am. Yeah. But you
Yeah,
can
yeah.
make a slideshow, ma'am.
Yeah, now is it visible?
Yes, ma'am. Yeah.
So I'll start once we are planning to set up a IUI lab. Let's have an overview of services and which kind of setup you can have a IUI lab. Normally in level 1, the primary setup, it contains only just OPD services in which the OBG deals with basic infertility services. But when we reach to level 2, it is here we need IUI setup, and wherever handling of gametes is required, it needs training, lab setup, and other few accreditations which I'll be speaking in my talk. And the tertiary level is basically when we are doing IVF. So the essential requirement which I'll be discussing about is the infrastructure, equipments, manpower, consumables, and record keeping is very, very important. So infrastructure, we need to have a OPD and an ultrasound. And then when the egg is ready, the trigger has been given, IUI is planned, then the next requirement is to have a good IUI lab where the sperms handling is done. And adjacent to the lab, there should be semen collection room and an insemination room, preferably side by, to inject the sperms inside the uterine cavity. So if we look at the infrastructure, generally for the lab, we need approximate region of 100 to 200 square feet. And as I've discussed, it should be adjacent to insemination room. And when you are planning the IUI lab setup, it is preferable that all electrical wirings should be concealed, and it is better to avoid false ceiling. And if you have to use an air conditioner, better to use a split or central air conditioner. The other one is not preferred because of the risk of contamination. And regarding the flooring, the preference should be large marble tiles or granite, like which we have in our setup, or large vitrified tiles can be used. Then the walls should also preferably be covered with tiles. Alternatively, one can cover wall epoxy paint. And if in future one is planning to convert IUI into IVF setup, then it is better to plan using pressure modules to create positive pressure in the lab. And a word about ultraviolet light, which I wanted just to mention, that normally in laminar flow also we have ultraviolet light. It should be switched on when you're out of the lab, because this can damage the eyes of the worker. This is very important point. So the sterility of the lab is very important. Before entering, change into sterile clothes, slippers, cap, and mask when one is working in the lab. Gloves used should be non-powdered gloves, and cleaning of lab walls and floors with 70% alcohol at the end of the day. Cleaning and maintenance of lab is very, very important. Coming to the equipment aspect, I'll be discussing one by one the basic equipments. It doesn't cost much to set up a IUI lab. The basic things which we require is a laminar flow, centrifuge machine, and a sperm counting chamber, along with phase contrast microscopes, which should have 10x, 20x, and 40x objectives, a small incubator, maybe a dry bath, and then test tube warmer, a refrigerator for the media, and cryocans if freezing is planned, and the accessories I'll be talking about. So the laminar flow, which you require, it could be either a vertical or horizontal. Usually vertical is preferred because the airflow is not directly at the face. And for IUI, this smaller laminar flow can do 1.5 feet breadth laminar flow. And it contains a stainless steel top, which is easier to clean and maintain. And some of the laminar flow, they contain a heated area also in front. And whenever you plan to prepare the sample, it's preferable to start the laminar flow half an hour or 1 hour before, so that the temperature is maintained, 37 degree, what we are aiming at, of the tabletop temperature. Then the next requirement is phase contrast microscope to test for semen for count, motility, morphology, and other components. And I've mentioned the objectives should be 10x, 20x, 40x, and 100x. Especially 20x is required when you're using macular chamber. So then we need to have a centrifuge. Centrifuge should have a timer up to 30 minutes and a rotor whose speed can be controlled, and it is better to go for a swing out rotor head. And you can have a simple Remy centrifuge, or you have other digital kind of centrifuge, Eppendorf, and other kinds. So that's a personal choice. Then for IUI preparation, a simple dry bath incubator can do, in which you keep the semen sample at 37 degrees Celsius for liquefaction prior to semen processing. And in case if that is also not there, this heating plate can do the work. You can place the jar on digital heaters whose surface temperature is set at 37 degrees centigrade. Then the CO2 incubator is optional. If you are using HIPPI's bicarbonate buffered media, then CO2 incubator can be used. And the next is the sperm counting chambers. We have Newbar chamber and Mackler chamber, which are non-disposable items. For sperm counting, you count the 10 squares and see how much million the count is. Then car size is optional. I'll not go in detail. And the simple small refrigerator, you need to keep the media. And apart from that, this is a photo of our lab, in which if you are planning for freezing facilities, then you can have cryocans and the storage containers for liquid nitrogen. And a word about microscope, if you want, instead of binocular, you can have a trinocular microscope also, because on that you can teach on the screen. You can show on the screen that how the sperms look like, the motility and the counts. So for teaching purpose, you can have a trinocular microscope. Regarding manpower, clinician, gynecologist, and the ultrasound can be done by gynecologists like it is being done at our setup. Then you have need to have a dedicated and trained lab staff, nursing staff, and a receptionist or a record keeper. Either the work can be done by record keeper or a receptionist. That's also optional in government setup. So we're talking about consumables, media, disposables, and IUI cannula that is required. I think this has been talked about in semen preparation also. I'll not go much into detail. We have ready-made media, and if we are using dry bath incubator, HIPPI's buffered culture media, the simple balanced salt solution will do. So coming to the disposables, they should be sterile, toxicity tested. Like we have polypropylene semen containers. Then you need this IUI cannula, the tubes, and the pipettes. This is the IUI kit for preparing the sample, which is required. Then comes IUI catheter. The choice can be the catheter should be disposable, non-toxic, minimal dead space, and semi-rigid is okay for IUI. And there are different types of catheter available which you can use. So important is whenever you're planning a IUI setup, certain certification is very, very important. At present, we are going for ICMR enrollment. Wherever we are handling the gametes, we need to have a ICMR enrollment. But the future, we know that the act has come up in recently, and there will be formation of state and national board, and we'll be having a national registry. Then apart from that, we need to have a PCPNDT certification. The rules are very strict about it. Then biomedical waste, like in Delhi, we have DPCC, Delhi Pollution Control Board. We have to register with that. And fire safety NOC is must. So these are the very important things which you need to plan before setting up the IUI lab. And the record keeping is very important. We have the ICMR forms. Whenever we are doing insemination, we have to take consent for artificial insemination or IUI with husband's sperm. These are the standard ICMR form which we are using at our setup. And this form is very important when you are taking consent for artificial insemination with donor semen, because it is very clearly mentioned, and you have to explain that the husband declare that should my wife bear any child or children as a result of insemination, such child or children shall be my own and shall be my legal heir. So this consent is very, very important. And you have to write the number of the ID from the semen bank from where the sample has been procured, and the records are to be maintained. Minimum, the PCPNDT says for 2 years, and then the ICMR, as per the consent forms, minimum 5 years, and then they have to be transferred to ICMR. Now let's see what the new boards which are coming up, what the changes there will be there. And regarding PCPNDT, the form F and form G, they are to be filled now, because recently we had a PCPNDT team coming up. And even for IUI, if you are doing IUI, you have to fill the form F and form G. And now they have told us that form D, whenever we are starting with the follicular monitoring, form D also has to be filled in all patients in which we are planning IUI. So this is the initial phase when we started with the IUI setup in our hospital at Basai Darapur. We had a demonstration, and this is Dr. Chandok. He was as HOD pathology, and we had a good collaboration with the pathology department. And this is what I was telling Dr. Krishnakant, that how we started with the IUI setup in collaboration with pathology department, where we used to go and perform the centrifuge. And then gradually we started our own setup, and we had our IUI lab inaugurated in 2016. And this is our IUI lab. We have all the freezing facilities at ESI Basai Darapur. And now we have come up with the IVF and Fertility Research Center, which was inaugurated in 2019. So we have reached a tertiary level setup now. So to conclude, what we need is a proper gadget, clean environment, standard protocol, and an expert hand, which are key to success. Thank you very much.
Thank you, ma'am. Thank you, ma'am, for elucidating the prerequisites and official proceedings that are required for setting up an IUI lab and the stringent conditions that need to be followed. Thank you. And any questions from the participants?
I think they're clear about it.
No more questions, ma'am.
Yeah. So now we will have some practical case scenarios moderated by Dr. Krishna Chaitanya sir and Dr. Panduranga Rao sir, Dr. Leena Vadva ma'am, Dr. Steve Richards, and Dr. Ravichandar, Dr. Deepthi Sureka. So Dr. Steve Richards, Ravichandar, and Dr. Deepthi Sureka are SRs in the Department of Urology. And yes, sir, please. So the session will be taken over by them. Yeah.
Thank you so much for that. I think we are running a little late by 10 minutes. It's okay to run the session a bit extended, or you want us to close by 5:05? Done. I'll try and keep it as simple as possible. So I think I'm just the moderator. I'm an embryologist and not a clinician. So I've got a team of expert clinicians with me. So from morning, from afternoon, we've been looking at a lot of concepts. So let's get all of that and see how we can actually effectively and efficiently manage man in a ART industry. So, so that's the first case. What we have, a young couple married just for a year. There was nothing significant in their history. They had a normal sexual life, but very anxious to conceive. A semen analysis was ordered, and it was 4 million with a 26% mortality and 6% normal forms. So who wants to take that question? How would you want to manage a couple of this history?
Yeah, Dr. Chaitanya, Dr. Leena this side. In such a case, when a young couple is coming for the first time with a single report showing oligospermia, in fact, the mortality is also little on the lower side. That should be around 32% if we combine A plus B. So in that particular case, it could be because of improper collection, or there may be spillage. So we need to repeat the test.
Wonderful.
So that is what we need to plan.
Wonderful. So any more comments there? Anybody who thinks that we should be doing some kind of medical management at this point, or refer to ART, or wait and watch, as Dr. Leena said? Everybody agrees on that?
Yeah, can I just give my opinion?
Sure, please.
See, there is only one sample here. So probably I feel we should have 2 more samples actually. 3 consecutive samples will give a very consistent result.
Totally agree with that, sir. So
yeah, so, yeah.
Look at the whole history. It's young couple, no treatments, the first semen analysis. So we will first want to rule out things which would cause oligoacidosis, like a spillage, improper collection difficulty. Sometimes it's just a prostatic fluid, and then a laboratory error, and then we go ahead with that. So, in a case like this, I think examination and giving assurance, counseling would probably be the best way of going. So let's go to the second case scenario. Again, a young couple, 2 years of married life. They had 2 IUIs because of the oligoacidosis. And the counts have been varying from 3 to 8 millions, has already taken antioxidants. So how can we proceed with this kind of a scenario? Dr. Steve or Dr. Ravichandra, Dr. Deepthi. The whole point is, there are 2 ways of doing it. Either we do some kind of medical surgical management, if at all there's a role, or do we directly go for ART? Can you help the audience get a little hang of this?
Some baseline investigation to rule out the cause of male infertility, to rule out infections, the examination of the male partner, any special ultrasound, maybe trust. So,
ma'am, I know that's wonderful to you point out the fact that, examine, a thorough history examination and interpreting the semen analysis solves a lot of issues, gives a lot of directives while we are managing the male. Most of the times we're just treating the reports, and when you don't have a background, it gets difficult. So in a situation like this, I think after we take the examination notes and everything, we could go ahead. So couple of points of how do you choose whether, if you're doing a medical management on whether it's a SCRM or an anti-estrogen like letrozole, how do you choose on that?
Yeah, normally what practically we do is we put the patient on antioxidants for 2-3 months. And commonly we use vitamin C and vitamin E, what we are using in our setup. But definitely we investigate the male partner. We test the, if required, the hormones, FSH, LH, testosterone. And if it is low, the testosterone, if it is low, then the options are there. But practically, I have not much experience in this. But yes, when the estrogen, like if the male is obese, the estrogen levels are high. In that case, the drug of choice will be letrozole because it inhibits the conversion of androgens to estrogens. So the patient can be put up on letrozole for 3 months, and the other choice is clomiphene. And we give the injections only in case of hypogonadotrophic hypogonadism. Otherwise, I don't have experience regarding that.
Anybody else who wants to add a bit to the medical management, because that is the first line. Most of the couples who come with oligoacetotereto are expecting that we as clinicians would do some medical management before suggesting them an IVF ICSI cycle.
Yes, the 3 consecutive samples they show reducing sperm count. So I don't think there is a role, because it is less than 10 millions per ml is a very severe oligospermia. So the role of clomiphene will be very much negligible in such cases. Medical management will be, I don't think it will be very effective. So better to go for some artificial reproductive techniques. That's what my personal feeling is.
So again, going back to the European guidelines, it says if there are 2 semen analysis less than 10 millions, we should be getting the whole reproductive hormone profile done, which is FSH, LH, testosterone, and estradiol at least. Then you look at a T/E ratio. Though it is not FDA approved, based on the T/E ratio, you can decide whether you're going to put them on clomiphene citrate or an aromatase inhibitor like letrozole. But as Professor Panduranga says, the role is limited. But if the patient is insistent and doesn't want to look at ART, that is something that we could consider. And that's a little guidance that probably is going to help us. So this is more to look at, is there an advanced way of treating? Because this couple is like mid-30s, 7 years married life, and 2 IVFs are already done because of oligoacetotereto. The person has come back again and it's got a count less than 5 million with the 20% progressive mortality. So in a situation like that, how would you want to proceed from a male side? Because ICSI was the choice. They've done ICSI 2 times. Now the 3rd cycle, is there anything else that we can do for the male part?
Has sperm DNA fragmentation test being done in this particular case?
No, Mom. Yes. So that is something that we can consider doing, considering that there is recurrent implantation failure. Since it is less than 5 millions, is there any other investigation that anybody would recommend?
Karyotype.
Karyotyping and a Y chromosome deletion. So I think I don't think there's a role of medical management here. In terms of advanced interventions, we get a sperm DNA fragmentation and karyotyping, and if required, a CISA or a microfluidic sperm sorting if we're looking at it. So the whole point of discussing this case is, sometimes it so means that ICSI is the end of the journey. And there are times where we said we've done ICSI, we've put embryos, you're not pregnant. Does the journey stop there? In the present day, with so much of advances in the field of embryology, we shouldn't be stopping it. There's so much that is improved with sperm selection and embryo culture system, and we could help such people out.
Yeah, Dr. Chaitanya, in this particular case, will CISA help to get the good quality of sperms? The fragmentation will be less, maybe?
That's been our is that again, we have to discuss the pros and cons. It isn't a magical therapy, but if somebody has got a raised sperm DNA fragmentation and is not responding to antioxidant therapy or a varicocele ligation, the last resort can be doing a sperm DNA fragmentation. A point that all the audience people need to note here is all these advanced interventions that we're talking about cannot be the first line of management. No, we have to take them through the first line of management. When things don't work out, that is where these advances are going to come in picture. You have to individualize the treatment for the couples coming in front of us, and then only go ahead with that. It probably might add on, but not guarantee anything. The word guarantee doesn't exist in the ART industry. But any questions from the audience of how we would want to deal a case of oligoacidotetrato? Any questions? The expert panel will be more than happy to take it. So I think any case of OAT, repeat sperm analysis, as Professor Panduranga put it across, we're going to take a thorough history and examination. That's very important. And then, if the counts are less than 10 million, you get the hormones done. Based on the hormones, you could decide if there's a role for medical management. And if nothing works, ICSI probably is the choice of insemination when it comes to a male factor infertility with severe oligoacidotetrato. So let's move on to how do we deal with a case of azoospermia. So a young person married for 3 years gave a semen analysis where the volume of the semen was 0.6 ml and was azoospermia. The guy got very anxious because somewhere they said you need to go ahead and get an ART done. So how, some action points with the case that comes across like this.
Dr. Chaitanya, in this case, the repeat semen analysis is normal. And initially, the report shows low volume ejaculate. So maybe we have to rule out retrograde ejaculation, maybe.
Yes.
In this
So we
particular
have to go for the ultrasound of the scrotum. Ultrasound of the scrotum has to be done. We don't know. See, the still proximal obstruction can be there. Oh, we don't know. This normal truss shows about the ejaculated ducts, prostate, and seminal vesicles. If something proximal is there, it doesn't. One has to again here see history and clinical examination is very important. Clinical examination as well as the scrotal ultrasound. Scrotal ultrasound will throw idea about not only varicoses and all that, but it will give idea about the epididymis and how the testis and all. Still, proximal obstructions can be there, not necessarily be there, but can be there. What do you say, Christian?
Yes, sir. I think that's the right way, sir. So first is, trying to offer TISA or some kind of intervention should be discouraged. I think first is counseling. It's only one report. There's low volume ejaculate. So as Dr. Leena was saying, we get a post-ejaculate urine examination to rule out retrograde ejaculation, or a simple thing like a spillage, because it is quite common for the man to spill the sample while collecting. We first rule that out. We then rule out retrograde ejaculation. If we've ruled out both, then we're thinking of some pathology. And usually the pathology should be with the seminal vesicle or an absent vas. So considering workup for obstructive azoospermia is probably later in the workup. Initially, it is ruling out simple things like collection difficulties, spillage, and a retrograde ejaculation. But if it turns out to be an obstructive azoospermia, where on examination of vas is absent and a rectal ultrasound is showing absent seminal vesicles, then alone we get a CFTR mutation done. Not every obstructive azoospermia would need a CFTR screening, because sometimes the obstruction could be post-infection or inflammation. Only if we have documented that the vas is absent or seminal vesicle is absent, then alone there's a rule of CFTR mutation screening, and then we proceed further to do the needful interventions, which is doing pre-implantation genetic testing, where we could ensure that the child in the future does not carry that particular deleted gene. So now there's another case of a 32-year-old man, azoospermia. History and examination are all looking fine, and even the investigations are looking fine. It's obstructive. It is azoospermia. We are able to palpate the vas. The volume of the testis is normal, and so are the hormones. So how would you want us to proceed in a situation like this?
Have we confirmed azoospermia in this case by repeat centrifugation?
Yes, ma'am. All of that is done. 3 samples with adequate duration. All of that
Truss.
Was normal as well, sir. There wasn't anything that was suggestive of an anatomical defect on the rectal ultrasound.
So it indicates a non-obstructive azoospermia?
So that's the suspicion. It's either non-obstructive or we've not ruled out obstruction just with the mere presence of VAS. So I think first thing, there's no role of medical management. Let's appreciate on that fact here. And usually these cases, because your VAS is palpable, doing a trial teaser is an easier way of handling, a quicker way of getting the couple down into the ART cycle. So we did a trial teaser, we froze the sample, and then we went ahead with ICSI because it sounded like unexplained. The genetics was also normal for us. So we didn't really waste much of time in this particular case. So again, for all the audience there, what we want to impress upon you all is when there's an azoospermia, you need to have a systematic approach. So have at least 2 or 3 samples repeated, get a post-ejaculate urine, rule out retrograde ejaculation, look at your history examination. Then based on what you have got in your history examination and findings of a semen analysis, plan for hormones or imaging. That will kind of tell you whether this is going in favor of obstructive or non-obstructive azoospermia. And accordingly, go ahead with that. I'm sure I'm sitting in front of a urology panel. You might not like me saying that VA has got limited role, but at least from an ART perspective, we have seen where the surgical retrieval is improved, our knowledge to handle sperms in the laboratory is improved, and the success with testicular sperm is on par with ejaculated sperm. So the attempt to do a VA correction, at least in the year 2022, has come down. What is your take on that, Dr. Panduranga or in the panel there?
We would appreciate it, but only thing is the economy part of it. If the patient is financially sound enough, that is nothing. Number one thing, and number two thing is time to move around. These are the two things. If he has ample time to move around and 32 years male, still take a chance if finance are not there. Finance are there pretty well. This is a better way. The ICSI, going ICSI for TSA, frozen TSA, ICSI, that may be a better proposition.
Spot on, sir. I think that is what even we were taught in medical college, is that, ART was not accessible at that point. This is 20 years back, not as much as it is today. And all that we could have done is ask the urologist to do an anastomotic surgery, which sometimes we could have seen sperms in the ejaculate. But with the surgeons of the surgical retrieval techniques that have improved and ART techniques that have improved, I think the role of VA is slowly coming down. But I think we need to individualize and see what the patient wants and then go ahead with that. So this was another person which the reports more sounded like a primary testicular failure because FSH was 32, testosterone was on the lower side, the genetics was normal. Teaser was done. It was showing a Sertoli cell-only syndrome, and they said nothing can be done, go ahead with donor sperm insemination. The person wasn't happy. So if such a patient comes in your OPD, what would you want to do as urologists?
Just I want to know from you, Dr. Chaitanya, do you still entertain in Sertoli only syndrome? So you think it is the pan appearance in whole testis, or you think there would be some areas where that may? Are there any trial microtesis in this condition, or where exactly microtesis can be tried?
So at least if we go with Cornell University, Sir, Weill Cornell, they've got a big microsurgical department. Professor Peter Schlegel heads the department. And a lot of his publications, if you see, he says, if there is a case of primary testicular failure, where the testicular volume is less and the hormones are deranged, he says the first attempt should be the best attempt. And he would recommend a micro dissection of the testis because you're using a bipolar cautery. The blood loss is less, the incidence of hematoma, scarring, and fibrosis are less, and you are searching these testis under microscope. So the retrieval is better. So he says in such patients where the prognosis is guarded, instead of doing a trial, directly go for a micro test. But again, microtesy is evolving. I think looking for dilated segments and doing it under microscope is definitely a better procedure than doing a blind procedure with a butterfly needle, which definitely puts the patient through hematoma and scarring. And again, this meta-analysis done by Sandro Esteves group in Brazil, I think based on the histopathology, they've predicted the prognosis. So if it is hypospermatogenesis, the recovery is very good, and micro-TC can be suggested. Sertoli cell-only syndrome also gives around a 30% chance. Because there was a point where we said that if it is a Sertoli cell-only syndrome, do not further do exploration of the testes, because the chance of getting sperm is very, very bleak. But now with micro-TC, the knowledge and technical skill going up, I think micro-TC can be an option. So again, it is about the patient's choice, finance, the cost of ART, all of this should be put across to the patient. It is the belief of the patient. Religious grounds, sometimes patients are not wanting to go with donor sperm, or personal choice, they do not want donor sperm. We shouldn't be forcing. There is a medical therapy that is available, which has got some limitations. If the patient is wanting to do it, I think we should be putting that on their platter. And I think micro-TC definitely has a role. But I think patience of the surgeon, because going pole by pole, segment by segment in the testis, and then the embryologist patiently teasing the tissue and looking at multiple samples, it's going to take at least 2 or 3 hours. A good micro-TC sitting takes a 2 to 3 hour session, and we as embryologists absolutely are exhausted at the end of the session. And if you're getting 10 or 15 sperms, you then need to have a system of either injecting into fresh eggs if the lady is ready for harvest, or you'll have to vitrify the sperms or freeze the sperms. So without a proper laboratory that has the knowledge of handling such cases, just surgeon doing the best might again not work out. So ART is a teamwork. We need a good clinician, a good embryologist, a good urologist. And the recent guidelines of the ART bill says all testicular surgeries should only be done by an MCH urologist. A gynecologist or a general surgeon is not entitled to do this. So I think we will be needing a lot of urologists who would be wanting to practice a bit of andrology, because I think male factor is the future. There's going to be lots and lots of male factor that's going to come up with the changing lifestyle. So we are hoping the urologists in this would actually appreciate this fact and look forward to take up a bit of andrology practice, because right now that's the need in the country. General urologists might not want to look at andrology because that's a very small segment, and there's a lot more that the urologists as surgeons could do. So that's a little picture of how a micro-TC is done, which Professor took us through the whole process, and we have a lot of advantages of that. So that's the end of the panel. It's just a little flow chart which says when there's azoospermia, take history examination, rule out retrograde, and then if it's obstructive, see what to do. If it's not obstructive, how do you go about? So genetics has a role. If it is severe oligoacino-crypto or non-obstructive azoospermia, we get a karyotyping or a Y chromosome deletion. Obstructive with an absent VAS, get a CFTR, otherwise don't get it done. If the post-ejaculate is showing sperms, then treat them as retrograde ejaculation. But there's so much more that you could do with a self-gamete conception. Donor is not the option in the current day for us. So any questions, any closing remarks from you all would be nice. Dr. Leena, I'm sure there's a lot.
Dr. Krishna Chaitanya, you have very nicely, wonderful. You have nicely moderated the session and everything is well covered.
Thanks, but yeah, any questions we'll be more than happy to take from the audience.
Nothing, I don't think everything has been covered.
Wonderful.
Nice interaction with you, Krishna Chaitanya sir. We'll try to see you personally.
Thank you, sir. And yeah, down the line, if there are any more workshops that you people want on anything related to fertility, anybody is really interested to come and see all of this advanced work, you're more than welcome. I think Professor Krishnakant has got all my details. We are happy to get observers to come, see, learn, and go. Knowledge sharing is something that we advocate at Oasis. So welcome if you really want to look at this and get this on board with you.
So I have one question, sir.
Thank you.
Thank you. Thank you.
Thank you.
I have one question, sir. Krishna Chaitanya, sir. Yeah, sir, do you have any like for if you go to the blood donation, you have some form like that? Is there any format available in your center for the people who wanted to
Thank you, Krishna.
for the infertility treatment? Any format which covers all the criteria?
For donor sperm, madam?
For IUI treatment, like say suppose anybody come for the treatment, so is there any donor form or some format, something like that it is there, which covers all the criteria?
Well, Dr. Leena did show us a little bit of those consent forms from the ICMR and ART bill. So I think they need to fill in, it has to be anonymous, and they sign in saying that enough counseling was given. And if you go through that consent form given by ICMR, it's self-explanatory. Every bit is so beautifully covered in that consent form. And it's free to download from the ICMR website.
Is it only for the male person or for the female also? Do you have any criteria as such when you're evaluating?
Yes.
I think you're confusing with two different things. One is the workup and the other is the consent form for the procedure. All the consent forms they are available.
No, ma'am, I'm not asking for the procedure. It's just a workup. Say, suppose an infertile couple is coming to your clinic.
Yeah, you have my number. We can share our forms which we have for the workup, and for IVF we have a whole file before we take the patient. But for basic workup and investigation, we have our own formats.
Okay, ma'am. Yeah, that's what I was asking, ma'am. Thank you.
Yeah.
Ma'am, there are quite a few algorithms that you could go on Google and download, ma'am. Because unexplained infertility is the usual.
I can share. You can have my number, and I can share whatever information you require.
Yeah, something like if we are doing immunohistochemistry for our tumor markers, we rule out, no, this is negative, this is gone, this is negative, this is gone. So something like that, any algorithm. So that's what is my doubt, ma'am. Thank you for an excellent talk. Yeah, thank you. Thank you, ma'am. Thank you, sir.
I would like this opportunity to thank ESI Medical College and Professor Head of the Department of Pathology, Professor Krishnakant, for this lovely, wonderful opportunity to show you all the work we do. We want this work to percolate down to everyone. We want this to reach everyone. Gone are those days where people think India is underdeveloped. We are no way underdeveloped. We have all the technologies, all the treatments available, and we're doing equally good job the way the Western world is doing. We just want we all to go out there and publish it and tell the world that we hate being called developing country.
I agree with you, Dr. Chaitanya. We are doing a wonderful, good job, and with all the facilities we have in house.
I'm amazed the way you people have set up your unit, ma'am, because the chunk of people are going to come to you. Not everybody can afford these treatments, and bodies like ESI can offer these kind of treatments. I'm sure the future is absolutely brilliant for us.
Thank you.
Thanks, ma'am. Thank you, sir.
Just a few comments from my side, sir. Leena madam, she's the leading the only ESI center that holds the IVF facility. Needs special congratulations for her work. And also Krishna Chaitanya sir, you have been very good at your academics, and you wanted to share this platform. And when first we thought of male infertility as a topic, we were finding it very difficult to motivate people and get speakers. And our search has ended with you. Actually, you have given us a lot more to make this happen. Especially thankful to you, sir. In spite of your very busy schedule, heading one of the leading infertility centers in Hyderabad, you could give some time to us. We are grateful to you. We want to meet you at your center too. With those comments, I hand over the session to our moderators.
Thank you.
And I would also like to thank the Department of Pathology, Dr. Krishnakant, and ESIC Medical College, Sanatnagar, where I had the opportunity to visit twice. So this was a wonderful workshop and I really enjoyed it. Thank you so much.
So herewith we are going ahead with a vote of thanks. First of all, I would like to extend my deepest sense of gratitude to our esteemed Dean, sir, the entire administration, our beloved HOD Dr. Krishnakant, sir, my fellow colleagues, and faculties from ESIC Medical College Hospital as well as Super Speciality Hospital. This CMA would not have happened but for the efforts of our urology team headed by Dr. Jagdishwar sir and his colleagues Dr. Ravindra Reddy sir, so as their SRs and faculties from our sister institutes, ESIC Medical College Hospital, Chennai and ESIC Medical College Hospital, Basai Darapo. Thank you, Dr. Meenakshi Sundaram sir, Dr. Leena madam, Dr. Kamta Prasad sir, for enlightening us in various topics. I would like to extend my gratitude to Dr. Sunit Jogi from the Department of Radiology for sharing his views on radiological aspects of male infertility. A special thanks to Dr. Krishna Chaitanya Mantravadi from the Oasis Center of Reproductive Medicine, Hyderabad, for his contribution of time, experience, and knowledge of male infertility. I would like to thank all sincere workers, our technicians behind the stage, for their help and support. It would be meaningless if I conclude the session without having a word for our esteemed participants, for without you all making this event a grand success is just a verbal note. Thank you, Dr. Ratna, for hosting this meeting, and Dr. Tejomai being as a co-host. Kindly pardon me if I would have left anyone without delivering the sense of gratitudeness. Finally, I thank the God Almighty, without whom I'm just nothing. Thank you all. Thank you one and all.
Special thanks to you, madam. Also, Ratna madam, she has taken all the technical burden on her shoulders and has made this a smooth run.
Thank you so much for the opportunity.
Yeah, thank you.
Yeah.
Thank you one and all.
Madam, you want to share
Thank you,
something?
sir.
Madam, you want to share something, madam?
No, sir, nothing. A small announcement regarding the feedback form we
Yeah,
have
ma'am,
posted in the chat box. Please pass it on. I think we will try to post the people who were not there in the mail also. But whosoever is present now, please try to fill the feedback form. So hope to see you all in the upcoming webinars also. Please pass on the message to your colleagues and other participants. So we'll come with much more topics like this, and any topic of interest, please post it down to Krishnakant sir. So we will try to sort it out and bring it before you. Thank you one and all. Thank you Krishnakant sir, Shakti, all the faculty of Medical College and my dear colleagues. So thank you one and all. I'll be closing this session in another 2 minutes. Whosoever haven't filled up the form, please do it right now. Thank you.
Thank you one and all.
Thank you, one and all. Thank you, sir.
Thank you, sir.